Hello, hello, hello. My name is Jill Osborne. I am the president and founder of the Interstitial Cystitis Network. It is Saturday, May 18th. It is our second scheduled support group meeting for May 2019. Our meeting tomorrow was rescheduled to today because I have a wedding to go to. So, guys, Facebook has changed things around. It took me about 20 minutes to find my go live button. Hi, Barbara. Hey, guys. First thing I want to know is, how is the sound? Can you hear me well? As you see right here is a microphone now. I want to make sure the sound is okay. So testing 1, 2, 3. How is the sound? Can you hear me? Whoops. I sound okay. Okay, so the sound is working on YouTube. Whoa! You know, there's nothing worse than thinking you're 30 minutes early, going to Facebook to set it up, and all of a sudden your how to make a post button has disappeared. Take 10 minutes to find the little plus sign on my profile. And then when I clicked on that, the Go Live was missing. It turns out Go Live is now in the Facebook Creator Studio. So I've been kind of going a little bit bonkers. So anyway, this is a support group meeting to make it for tomorrow. And for those, and I'm not quite as organized because I had to figure out how to go live on Facebook again. So guys, the reason we do these support group meetings is to make you so strong, so knowledgeable, so informed that no one can mess with you. I don't want anybody to be able to mess with you anymore. We are long past the days of thinking that IC is all in your head. It is not all in your head. We are long past the days of thinking that you are hysterical. We are long past the days of thinking that this is incurable. We are long past the days of thinking that we are worthless, that we are unlovable. I see 20 years ago, 10 years ago, was a bit of a grab bag diagnosis. Anybody who had unexplained frequency urgency pain were thrown into a diagnosis of IC. And if there's one thing we know, now, guys, I've been doing this since 1993, 26 years I have been an IC support group leader. And even back then, we knew that some patients did not respond to certain treatments. Elmeron, although it was approved in 1996, certainly it's not the perfect treatment for everyone. In fact, it really has a pretty low effectiveness overall. Why? Why does one treatment not work for everyone? The answer is because we are incredibly diverse. We are not the same. Some of you have symptoms that began after having a baby. Others of you had symptoms that began after a car accident. Some of your symptoms began in childhood. Others, your symptoms began after menopause. There is tremendous diversity in this IC patient population. And you go back 20 years ago, you know, back on the original IC Network website, we had the biggest online library of IC research. I'm telling you, every single research study was cataloged. It was insanity to maintain. It was so hard to maintain. And what you saw in those studies is marginal effectiveness. Like, there wasn't a single study that worked for 80% of the people. Okay, why? Because you can't throw patients with Hunner's lesions in the same study that you throw patients with pelvic floor dysfunction in. It does not work. It's like treating apples and oranges and grapefruits and avocados the same. We are not the same. Now, if you notice here, we are having a massive storm here in California, and the lighting is all really weird. So if I keep fading in and out, those are clouds coming in. If I disappear suddenly, that means the power has gone out. Today is going to be an adventure. It's just going to be an adventure. So what we are all now desperately trying to understand and do is understand what your unique variation of IC is so that we can find the right treatments for you. I tell every patient, you are an anatomical mystery to be solved. We want to understand what your unique presentation of IC is so that we can focus on the right treatment for you. I always tell patients, listen, when you go to the doctor, please don't walk in and say, I have IC. Don't do that. You're going to fall down the IC rabbit hole. I want you to focus very specifically on your treatments. Hey, doctor, I have this specific pain. I have pain at the end of urination, or I have discomfort as I urinate, or I have burning on my vulva as I'm peeing. Your job is to engage in a dialogue with them about what could be triggering your symptoms. And again, don't fall down the rabbit hole of IC. I don't want IC coming out of your mouth for 5 minutes minimum. Instead, what I want you to do when you prep for your appointments is, number one, make a list of your symptoms. And I don't just want you to make a list of your daily symptoms of frequency, urgency. I want you to write down your weird symptoms, the symptoms that happen randomly, like your feet tingle when you have a bowel movement. Anybody else do that? I do that. It's weird. It's because there's a nerve right next to my bowel. Or occasionally you get a shooting pain down your leg. Or, and what I call one of the dirty secrets of IC, you have moments when you have this weird arousal sensation. It's kind of a hurt so good, but hurts so awful sensation, which is actually the pudendal nerve being irritated, usually by tight nerves. Okay. I want to know the weird things that are happening, the random little things that are happening. I want you to make a list of what makes it worse. Is it worse when you sit down? Is it worse when you stand up? Is it worse when you bend over? Is it worse when you have sex? When does it feel the best? Does it feel good in the morning? Are you sleeping okay? But as soon as you sit on the side of your bed, it starts hurting? Hello, friends, pudendal nerve entrapment. That's what that is. I want to know, what do you naturally turn to feel better? Some of you instinctively go take a hot bath or a hot shower and you feel better. Why? Because heat relaxes muscles. Heat relaxes muscles, which helps us maybe look at your pelvic floor a little bit more. So I want to know, what do you turn to? What makes it better? What makes it worse? What time of day is it good? What time of day is it bad? Little random things. Sometimes it's a little tiny thing that actually helps us solve the mystery of your unique presentation of IC. And then it's really, really important to do a little bit of avoiding diary. I mean, you got to understand that your doctor isn't with you in the middle of the night when you're crying your eyes out. They have no clue what you're going through. You might say, I'm getting no sleep, but they don't understand the power of that. They don't understand the impact that is having on your life. Really important for at least a day or two to do avoiding diary. Write down, if you can write down in a small notebook, let's see, like this. I mean, seriously, get yourself a little round notebook like this, right? Every day, make every single day, make every page a day. And I want you to write down the time that you pee and an approximate volume, and then rate your pain on a scale of 1 to 10. Okay? The importance of doing that, and maybe a bigger one would be better than this, is that this will allow you to track your symptoms. This will allow you to show your doctor how frequently you are peeing. This will allow your doctor to see where your pain intensity is. And most importantly, you're going to give a copy of your avoiding diary to your doctor for your medical records. Why? Because it becomes evidence So if you ever do end up having to go through Social Security disability, which we hope you won't have to, you will have voiding diaries in your files that you will be able to use to demonstrate that you really do have symptoms. Okay. But this is about preparing for your doctor's appointment. This is about being able to communicate with your doctor about what's happening with you. And this is also when I don't want you to be shy. Please do not be shy. Seriously, if you say, I have pain down there, oh my God, don't do it. Come on. You got to be specific here. I want you instead to say, I have pain internally inside my body or externally outside my body. And I want you to try to be able to verbalize where. Is it in your urethra? Is it in your vagina? Is it in your bladder? Is it in your prostate area? Is it in your testicles? You know, it's so interesting. I was working with a patient last week and we were, and there's some people, it's like pulling, I forget the word, man, you're just like pulling to get their information, to get them to say, to describe what's going on with them. And it's like, okay, is your pain inside your body or outside your body? And she's like, oh, good question. I'm not sure. It's like, okay. Can you touch where the pain is? Yeah. Okay, that's outside your body. That is outside your body. And ultimately, in the end, what she was having was vaginal symptoms. She just couldn't differentiate and distinguish between bladder symptoms and vaginal symptoms and vulvar symptoms. So your ability to be able to describe this is important. The other thing I really want you to do, seriously, is, for God's sake, would you get a mirror and look at yourself? I mean, there's nothing, you have to know. Yeah, like pulling eye teeth. Thank you, Donna. I got a little flustered this morning when I couldn't start my stream for 30 minutes. So, well, my original walk into this got a little disrupted. So, all right. So, oh God, what was I saying? See, I'm telling you, I'm flustered. Holy hell. Okay, so we were talking about that patient, right? And she was having external pain. She couldn't distinguish between vaginal pain and bladder pain. So we got that worked out. And damn it, I was going to make a point. I'm sorry, guys. It's a Saturday. Been a long week. Oh, I got to tell you what happened yesterday. Let me ask you, okay, so where does the support group leader go for support? You know what? I come to you guys. And so how many out there use coconut oil on their vulva? Does anybody use coconut oil on their vulva? Hey, listen, I have no shame. I will talk about anything. If you want to talk about hemorrhoids, I will talk about hemorrhoids. If you want to talk about sex, I will talk about sex. If you want to talk about vulva or painful rectum, I'm your girl. I am more than happy to do it. So anyway, when I was in my 20s, I had really terrible vulvodynia for about 5 years. And we got all the nerves calmed down and life went on. And guess what? 4 months ago, bam, it's back. It's back. And it was started because I was sleeping with a really, really hot heating pad this year. I don't know. It got really, really cold here in California in February. And so I normally heat my microwavable heating pad for 3 minutes. I started heating it for 4 minutes, really, really hot. And it's one of those really long heating pads. And so it would actually kind of go all the way down to my crotch. And I cooked myself up a nice little yeast infection. And so anyway, I've gone through 1, 2, 3, let's see, I've done 2 clotrimisols, 10 days of diflucan, 2 tubes of nystatin. So I've gone from being, I know what I was talking about, really, really bright red. Now I'm almost normal, but I still have, like little moments of like, ew, what the hell's that? And so one of my guy friends said, Jill, do you use coconut oil? I'm like, no, no. And I did a little more research, found it has antifungal properties. So I've been using that for about 4 or 5 days, and I'm quite happy about it. So hey guys, if you have dryness down there, if you think you might have superficial yeast or whatever, there you go. All right, so what that was oh, the point that I was trying to make before I lost my train of thought was that I really, 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 really need you to look at your body. Please look at your body. You have to look at your body. What color is it? What is it supposed to be? When I looked at myself with that yeast infection, I wasn't just the color of this shirt. I was the color of blood. It was terrible. When I actually went to an urgent care appointment for this, the doctor gasped when he looked at my vulva. He was like, "Oh my God, this is terrible." And I'm like, "Yeah, I'm crying. Could you please help me?" And he did a big swab with this metal scraper, like all the way down this red tissue. It's like, ow, oh God, no. Ow, ow, ow. Right. And then he goes, "Well, we better check you for herpes." And I'm like, dude, I haven't been in a relationship in several years, tragically. It's impossible. He goes, "Yeah, but I got to do my due diligence." So again, you go through the whole sexually transmitted disease thing, right? Like, how many of you out there, I swear to God, we have been tested for every sexually transmitted disease known to man, even if we haven't had sex in a year. It's so absurd. And so anyway, so I get nailed with the equivalent of a razor. And he does this thing. All the tests come back. He looks at it under a microscope. He goes, "Yeah, I say yes." It's like, "Hello, dude. That's why I'm here. I don't want to be here. That's why I'm here." So anyway, I did a month long with him. Finally made an appointment with my gynecologist. It normally takes 2 months to get into. And I saw her last week. And she goes, what did she say? Oh my God, it was so absurd. So like she did a swab or something, and she looked and she goes, "Well, I don't see anything." And it's like, "Yeah, you don't see anything because I slathered a tub of nystatin on my vulva, 2 tubs of nystatin on my vulva in the last 3 weeks. There's nothing there. However, every now and then it'll last for about 8 hours, and then it'll get irritated again." And I told her it's like chasing a yeast infection. First, it's the left side, a little bit of prickling on the left side. Then it's the right side. Then it's up front. Then it's in the back. It's like, oh my God, right? And so she says, "Well, let's do another round of testing." And again, I mean, seriously, guys, how many times do I need to tell you it's not sexually transmitted? And her last thing was, she says, "I can't explain the prickles. I just don't get it." And it's like, I'm telling you what it is. It is a yeast infection. It is in all likelihood, Candida glabrata drug-resistant yeast infection that we're just keeping barely controlled with the nystatin. And her last thing was, "Well, let's just do a biopsy." Holy hell. Sometimes being a woman, having pain down there and being a woman sucks. Especially when she's like 20 years younger than me. And she has no clue what dry vulva feels like. I was like going over, is this estrogen atrophy? Is this a drug-resistant candida infection? Or is this some sort of chemical irritation? All right. So anyway, I don't know. Like, holy hell. Sometimes it's just holy hell. You get tired of it too. I mean, it's been 3 months now of a vulva not being normal, and sitting is not comfortable. I haven't worn jeans successfully, I think once in 3 months, because it's been irritated down there. I even tried this morning. I couldn't do it. I had to take them off. All righty. So normally, guys, what we do is I do a little educational intro. It's gone to hell today, combined with taking your questions and stuff like that. However, I did want to share a couple of interesting things with you. So let me pull it up real quick. So the International Painful Bladder Foundation is an organization over in Europe. And I knew them many, many years ago when we all used to work together as IC groups. We had a international IC patient network, believe it or not. And we had the Canadians were involved, the British were involved, we were involved, the Germans were involved. Another group was involved, and we used to meet at meetings, and it was really, really good until there was this massive fight between two groups, and it destroyed the whole thing. I wasn't involved with that, but as in nonprofits, things happen. But anyway, the International Patient Network, International Painful Bladder Network, is alive and kicking. They don't work with patients like we do. But what they do is really good summaries of research. And I just got one from her, and her name is Jane. She's in the Netherlands. And I have to say her summaries are truly exceptional. And in fact, I emailed her and I said, another excellent summary, Jane. I think the mycology studies are fascinating. And that's what I want to talk about a little bit. So her website is, I think it's painfulbladder.org, International Painful Bladder Foundation. And if you're a geek like I am and a nerd like I am, and you like to read the research, sign up for her newsletter, because I don't have the time. She's doing what I used to do 20 years ago. It's really clear and well categorized reviews of research. I just don't have the time to do it. I haven't for 5 years now. And in this summary, so a couple of important things: the Interstitial Cystitis India group, ICI, is working like gangbusters now. It's the first really, really active group in Asia. Really, really happy to see that. The German ICA has now released their own IC guidelines in English rather than German on their website, which is cool. A lot of those early groups, everybody had the same name. They just shared the name ICA, but that's all changed. People are really picking their own names now, but the German ICA kept using ICA. All right, so here, let me find this research study that I thought was so cool. Urinary fungi associated with urinary symptom severity among women with IC. This is done as part of the MAP Research Network. So you guys know that we're doing, one of the reasons why we now understand that there's such tremendous diversity in the IC patient population is because of all the next generation testing. Now, using next generation DNA sequencing, we can look much more closely and much more accurately at what is in a urine. Urine is not sterile. The bladder is not a sterile organ. It turns out there is a very, very robust population of bacteria that are supposed to be there. It's supposed to be there. And of course, we can get bladder infections of pathological or pathogenic bacteria. I'm sorry, pathogenic, not pathological, pathogenic bacteria. But for any of us to assume that urine is sterile at this point in time is ridiculous. We know that the human body needs beneficial bacteria. We also know now that the bladder can have viral infections. Who knew? We get viral sinus infections, we can get herpes, we can get HPV, but can a virus affect the bladder? Yeah. And in fact, two viruses, the polyoma BK virus and the Epstein-Barr virus, is now associated with the development of Hunner's lesions, which then helps us understand why patients with lesions never responded to Elmeron. Again, kind of how I started at the beginning. So one of the other really interesting points is, what about fungus? What about fungus? Now, we all know as I explained earlier, candida is a daily reality for some of us. If there's ever a patient who's been overexposed to antibiotics, it is you and me, the lower urinary tract patient. Some of you have taken antibiotics for 20 years, right? I haven't taken antibiotics, I'm going to say in 5 years. I really try not to take antibiotics. But our biome has been so terribly disrupted by antibiotics, really from the time that we were a fetus, because there was a good chance that your mother was exposed to antibiotics. And when you take an antibiotic, you kill good bacteria. So we don't even really know what a normal human biome is. We don't even know what a normal urinary biome is. But what we do know is when you take antibiotics, you destroy the symbiotic relationship in there. Because normally there's bacteria and fungus, and they keep each other in check. They keep each other in check. But when you kill the good bacteria that keep the fungus in check, then you get a fungal infection. So this is interesting. This is a study from the MAP Research Network that said the purpose of the study was to correlate the presence of fungi with symptom flares, pain, urinary severity in a prospective longitudinal study of women with IC enrolled in the MAP Research Network. Flare status, pelvic pain, urinary severity, midstream urine were collected at baseline 6 and 12 months from female IC patients with at least one flare-up, and it was compared to age-matched participants with no flares. PCR testing coupled with mass spectrometry, which I've actually done that, was used to ID fungal species and genus. Associations between the mycobiome stands for fungi, mycology, rather than biology or bacteriology. Mycobiology is about fungus. So associations between the mycobiome and current flare status were evaluated using generalized linear mixed models. Yeah, you don't know about that. The most specific analysis detected 13 fungal species from 8 genera, which are types, in 504 urine samples from 202 women. A more sensitive analysis detected 43 genera. No overall differences were observed in fungal species or diversity by flare status or pain severity. Longitudinal analysis suggested greater fungal diversity and a significant greater likelihood of detecting any fungal species in high versus low urinary severity participants. Individual analysis showed a trend toward the presence and relative abundance of Candida malassezia, which is only identified in the high urinary severity phenotype. This analysis suggests the possibility that greater symptom severity is associated with a urinary microbiome in some women with IC. And I didn't even read half of it. You want to talk geek speak? This is geek speak. All right. So what we knew 5 years ago, again, from the MAP Research Network, the MAP Research Network is a multidisciplinary approach to the study of pelvic pain, IC, prostatitis research team funded by the National Institutes of Health. Their research is nothing short of astonishing. Any study that they release is really important for us to look at. 5 years ago, as they were just starting to do this next generation testing, they were able to determine that patients having flares often had overgrowth of fungi in their urine, Candida specifically. And this study confirms that. This study shows that for some patients, the worse your symptoms was associated with changes in the microbiome, changes in fungus. I find that fascinating. I find that absolutely fascinating because I'm really absolutely fascinated by the biome anyway, and the fact that we are legacies of antibiotic use. I mean, I'm older than a lot of you, and I was born in 1960, right? So my mother was in the first generation of people using antibiotics. And so how did that change her system? And then as her child, how did that then impact my system? And are we functioning normally? Do we have a normal abundance of good bacteria versus bad bacteria? And the answer is probably not. Probably not. The reality of antibiotic use is that it kills important good bacteria. So I think that that's really, really interesting. I haven't read the actual study because I don't have access to that journal. It's a World Journal of Urology. And I just got this last night. So I didn't have time. I didn't have time to get it, but it does look like I can actually buy it. You watch, it's probably going to be $30 to buy. No, $40. It cost me $40 to buy this article. 56 people have already downloaded it. Fascinating. So I will probably, I think I'm going to buy that. I will go ahead and buy that, and we'll do an article on that in our magazine. Let's see what else she had in here that I think is interesting. Another, the thing about researchers that they kind of frustrate me is that they live in the lab. They live in the lab, and they don't talk to people like us. And it's like, you know what? We've got good information to offer because, hello, we are the IC patient, right? And so there's another team that is like really working on flares. And it's like, guys, if you talk to patients, we can tell you, you're going to have a flare. Potentially, if you eat the wrong food, you're going to have a flare during a period of high stress. You're going to have, a flare if you take a long car ride, yada, yada, yada. And so anyway, there's another team at the MAP Research Network working on flares. 24% reported no flare out of a population of almost 400 patients. 24% had no flares, 23% had one flare, 28% had 2 to 3 flares, and 25% had more than 4 flares, up to a maximum of 18 in an 11th month. All right, hold on a sec. Here on Facebook, what are you guys talking about Amazon here? Somebody's talking about selling something on a. Yeah. All right. And you guys, I do have the new thing. Oh boy. I do actually have bladder builder. Bladder builder. We'll talk about that in a minute. But let's just finish going through this research real quick, and then we'll talk about that. And I want to talk about next gen testing too. Actually, let's just talk about the next gen testing right now, because Kim over on Facebook is saying she's kind of starting all over and looking at the biome and maybe doing next gen testing. So, and again, a patient last week got her next gen testing results, and she couldn't get any doctor to look at them, which was very, very frustrating, and had to finally call the company to find another doctor who would help them. She had 30% streptococcus in her next generation urine testing. So for those of you who don't know, if you go to bladderhealth.org, you can actually order next generation urine testing. They will send you a kit. You will pee into a cup. You will use a little funnel to put it in the testing container. You will FedEx it back to them. You don't have to worry about ice or anything like that. Okay. And what they do is they use PCR testing and then another type of testing to actually study the DNA of anything that's in your urine. So when I had this done 2 years ago, or a year ago, it was a year ago, I had cloudy urine for months and months and months. I wasn't really having bladder symptoms. I had cloudy urine. I wanted to know why. My test came back with normal bacterial flora along with 3% streptococcus. 3% streptococcus. And so it's like, all right, what the hell do we do with this? Send it to urologists, send it to my gynecologist. They were like, well, we don't know if it belongs there or not. We don't know. Maybe you're supposed to have 3% streptococcus. We don't know enough about what a correct urinary biome is. And because I was not having symptoms, I chose not to take antibiotics. And eventually my urine cleared up. My urine is clear now. And when we interviewed in our magazine, the IC Optimist, the CEO of Microgen, one of the questions I asked him is, at what point in time do you know when to treat? And he said, two ways. It's not just about what you see in the lab results, it's about your symptoms. If your lab results come back with 4 or 5 different bacterial species, actinomyces, whatever, lactobacillus, maybe a little tiny bit of enterococcus, maybe a little tiny bit of strep, whatever. Do you treat it? And his answer is only if you're having symptoms. If you're not having symptoms, and if you don't have any other active signs of active infection, fever, discomfort, whatever, then we cannot necessarily say that it's a real infection. I mean, that it's a pathogenic infection. Now, if you have fungus in your urine, candida in your urine, that's far more interesting. That makes sense to treat. But with the bacteria, we're still a little bit, we don't really have good baselines right now, except for the patient that I worked with a couple days ago. And in her case, really strong symptoms. They're not responding to therapy. And when she did her next gen testing, she had 30% strep. And she called me and she goes, is that normal? And I went, no, that's not normal. That's definitely not normal. And her symptoms were the point that she was really crying. I mean, she had been in tremendous pain and discomfort for months. And the challenge for her is that it was not responding to the antibiotics that they were suggesting. But she had had a urine test last October, and then she'd had a follow-up test in December. And the follow-up test after the first 2 months of therapy showed a slight improvement, but she's still suffering. And I asked her, I said, have you done it again? And she had not. And ultimately, when you're doing next generation testing, you kind of have to follow it up and see where you are and maybe do another test a couple months later or 6 months later. She also, she was so desperate, she paid almost $900 to another company also doing DNA testing, only they also look at viruses. And of course, they didn't find any viruses for her. And she said, Jill, I have spent so much money and we cannot figure this infection out. And I just spent $900 with this other company. I went, $900? What? Microgen charges $199. Why would you pay $900? And she was just desperate. And it gave her no valuable information, really. It didn't help her change her decisions. So, that we're kind of stuck between a rock and a hard place with respect to understanding good bacteria and bad bacteria. And ultimately, in the end, you have to focus on what your symptoms are too. I think having the testing is important. It is a good piece of hard evidence. I mean, if that comes back 30% strep, and when you have a test with Microgen and they give the antibiotic testing, sensitivity testing results, that's the really cool thing about next generation testing is there are giant databases at the Center for Disease Control or the National Institutes of Health, one of them, millions and millions of bacterial DNA profiles. And so they don't just test for antibiotic resistance, they identify the gene. So they will tell you what genes you have that bacteria has that shows what it's resistant to. And when I had mine, I had a really weird bacterial resistance gene to it. I don't even remember what it was. I got it here somewhere. To an antibiotic I'd never taken. I'd never ever taken this antibiotic, and I can only assume that I got it through food, All right, let me just see if there's anything interesting. So anyway, you got this small group doing flares. Yeah. It's like, guys, just talk to patients. We can tell you what flares are all about. Another study on sensitivity, sensory sensitivity, the IC subtype 5 central sensitization. And again, it's kind of supporting the concept of central sensitization or a central pain phenotype for some of us, a small percentage of us. Here's a culture-independent analysis of the microbiota of females. And this was more next-gen testing. Urine specimens for 181 women. Yeah. Found a total of, this is cool. 92 species in their urine. 92 distinct species of living things in our urine. But it wasn't different from their controls. IC patients trended to have an overabundance of Lactobacillus gasseri, but had a lower prevalence of Corynebacterium compared to controls. The relative abundance mirrored the prevalent. No cause or effect can be drawn from this observation, but it suggested a more comprehensive evaluation, vaginal bowel, catheterized bladder, and tissue-based specimen of the lower urinary tract microbiota is warranted. Hello? They're saying, let's do some testing here for those patients not responding to therapy. Something else that we have a yet another publication from Emory University on the strength of association between Elmeron and novel maculopathy. This was published in Ophthalmology in April 2019, last month. And they're just showing that they're finding more patients, pretty much. Let's see, some of these are just really nerdy. You don't need intravesical injections of platelet-rich plasma is effective and safe in the treatment of IC. Platelet-rich plasma is a kind of a new therapeutic approach for a number of conditions. Not that familiar with it. This was done in Taiwan. They're saying all 40 patients completed 4 injections. Success rate was 45%, 52, 70, 70, 67%. Okay. I'll try to get you more information on that. And the study on IC in cats. You guys hear? Did you hear, by the way, that the grumpy cat died of a urinary tract infection, 6 years of age? And I really, really, really have to wonder if grumpy cat actually had untreated interstitial cystitis or stones. You know, whenever you have stones are covered with bacteria. If they were feeding him a really, really bad diet, cats will throw stones, and those stones are covered with bacteria. But it's very interesting that grumpy cat died of a UTI. Here's a study on Elmeron, study on hyaluronic acid. Here's one. Is bladder blood flow an etiological factor for bladder pain syndrome? And the answer was, yeah. What they found in this study from Turkey, interesting. They investigated bladder blood flow and internal iliac artery resistive indices in patients with IC-BPS. 30 patients were studied and 30 controls. The blood flow of the right and left internal iliac arteries during empty and full bladder were significantly lower in the bladder pain group compared with control. Although it was not a significant difference, the mean resistive index of the arteries was lower than the control group. Aging decreased bladder blood flow volume, and both BPS and control, decrease. The internal iliac artery blood volume was still lower in patients with bladder pain. It was concluded that arterial blood flow of the bladder was lower at patients with bladder pain compared with control group. The decrease in vascular supply of the bladder might be one of the related factors of BPS etiology. And I want to yell at them, pelvic floor dysfunction. When you've got tight muscles, it restricts blood flow. And it would have been really interesting if they had actually studied those patients with respect to if they had tight muscles that could be contributing to that. Oh, yeah. More. You want to hear something geeky? Here's a title. Welcome to my life, guys. Molecular taxonomy of interstitial cystitis bladder pain syndrome based on whole transcriptome profiling by next generation RNA sequencing of bladder mucosal biopsies. macrophages, neuregulin. Functional effects of blocking VEGF signaling in the rat urinary bladder in acute and chronic CYP-induced cystitis. Yeah, that doesn't help us at all, my friends. Well, anyway, we'll be going through a lot more of this research later. I just got this last night. I just thought it was interesting, and I thought the fungal thing was really, really interesting. Here's another one. Oh, here's another biome study, the urinary microbiome and anti-cancer immunotherapy, the potentially hidden role of unculturable microbes. Oh, let's read this just for a moment. Several urinary disorders, including overactive bladder, urinary incontinence, and interstitial cystitis, are often characterized by negative urine cultures. The application of metagenomics, which is next generation testing, to urine samples has enabled the identification of previously undetected bacteria contributing to the discovery and characterization of the biome. The most frequent species isolated are Lactobacillus, 15%, Corynebacterium, 14%, Streptococcus, 12%, Actinomyces, 6%, Staphylococcus, 6%. Although several studies are emerging in this context, the role of urinary microbiota in the pathogenesis of infections and in tumor carcinogenesis remains unclear. Furthermore, data on the activity of gut microbiota and modulating sensitivity to immune checkpoint, oh my God, to immune checkpoint inhibitors in advanced cancer patients suggests the influence of the urinary microbiota on tumor response to anti-cancer therapy should be investigated. Oh, that's way over my head. All right, well, there's more. All right. Oh, welcome to Life in the IC Geek Stream. Yes, indeed. Yes, indeed. So Lou Eddie, what do you take for a bladder infection if you don't take antibiotics? Hon, you got to get your listen, you cannot allow yourself to have an active infection that's not treated, because it can progress up to your kidneys and develop a kidney infection, and then bam, there you go. You could have a fatal infection. We don't want you to do that. If you have a bladder infection, it needs to be identified correctly and treated correctly. Eileen says, wait, it's not Sunday? Yeah, I know, Eileen. Hey, I've got a wedding to go to tomorrow, so I decided to do it today. I announced that 2 weeks ago. I got 2 weddings. I got a wedding this month, and I got a wedding next month, both on Sundays, on stream Sundays. Just looking at your questions. So Tamara uses something every single day and you swear by it. I'm wondering what you do every single day. What is it? Maddie says, why do installations help half the time? Sometimes relief, sometimes way more agitation. Well, really for 2 reasons. Number one, you can have different flares. You might have a bladder wall flare one day that the heparin lidocaine installation would help with. And then the next day you're having a flare, but you might not realize it's a stress flare, or it could be a pelvic floor flare. If it's a pelvic floor flare, a rescue installation is not going to do anything for it. You also have to understand there's a cumulative effect. And this was something that kind of came to me early after I was diagnosed with IC, that, some days your bladder's more vulnerable than other days. So as an example, you might be able to get away with an acid in the morning, but what if you have an acid at lunch? Then you got 2 acids on your tender bladder wall. And what if you have an acid for dinner? So you've got 3 acids, 3 exposures to strong acid if you are IC subtype 1 or IC subtype 2 Hunter's lesions or bladder wall driven. So you're going to flare based upon the foundation of residual irritation and inflammation in your bladder wall anyway, right? I wrote a blog, Anatomy of an Utterly Ridiculous IC Flare. I don't remember. I did something stupid for breakfast. I don't remember what, I put like salsa on eggs. And then I had a pineapple juice smoothie for lunch. And then I think I had tomato sauce spaghetti for dinner. And I was up all night bawling my eyes out. but we didn't really know about diet so much back then. I mean, yeah, you've done it too. You've done it too. JJ says she uses a little bit of garlic to stop yeast. Yeah. Yeah, somebody was saying, crush up some garlic and just put it in your coconut oil and use that. I've never done that. I was reading something though that garlic can be can burn also. So I don't know if I'm quite comfortable saying that. I've never done that. But the whole yeast thing is annoying as hell. Hello from Brussels. Hello there. Nice to meet you, Anna. Maddie says her doctor advised her to insert a pill of Valium, diazepam in her bladder, not taking it. Yeah. I mean, not in your bladder, in your vagina. Yeah, that's one of the ways of doing it. Doctors have suggested that for many years now. But, a vaginal Valium suppository not only has Valium in it, but maybe a base that makes it a little bit easier to insert. So that might be a little bit better. JJ's doctor will not give her Valium after 27 years. I'm so frustrated. It does help. JJ, what about baclofen? Will they give you baclofen, which is non-sedating, BACLOFEN? Hello, Catherine from Alaska. Nice to meet you. Cheryl says, I have Hunner's lesions, pelvic floor pain. I pee every 2 hours, or sometimes every hour, or even every 20 minutes, day and night. I get no sleep at all, so I know it's affecting my health. I can't seem to get any longer than 2 hours without peeing. All right, so Cheryl, dear, because you have Hunner's lesions, that means your IC subtype 1 Hunner's lesions, and so your pelvic floor dysfunction is probably a result of the lesions. When your bladder is screaming in pain, the muscles in the area will get tight to protect you. We call that a guarding reflex. And so in your case, your Hunner's lesion primary, pelvic floor secondary, for sure, 100% for sure on that. So the question is have you had your lesions treated correctly? That means they're either going to be lasered, fulgurated, injected with a steroid. We had a treatment which cured Hunner's lesions in 2 weeks called Liris. Allergan is sitting on it. They have deprioritized it, even after research studies showed it healed lesions. Or hyperbaric oxygen. In our latest magazine, we did a story on hyperbaric oxygen. Here, guys, hold on. I got to go get a sweater. Hold on. I'm a little cold. Sorry about that. I got this at J. Jill. I love it. How cool is this? Look at that. It's a shrug. Never had a shrug before. I really like it. Perfect for spring. Perfect for spring. All right, hold on. All right. All right, so Cheryl, again, you got Hunner's lesions, you got pelvic floor. So There's nothing sadder than patients who have Hunner's lesions and they haven't been treated. They're not going to respond to Elmeron. They're not going to respond to bladder installations to the degree that they're going to respond to lesion-specific therapy. So if you look at the American Urology Association guidelines for IC, they say lesions need to be treated specifically with lesion-directed therapy. So steroid injection, usually triamcinolone, cauterization, fulguration, laser therapy, or Lyris, if you could get it. Unfortunately, we can't because Allergan has deprioritized it. And of course, hyperbaric oxygen therapy. Let's see. This is this was our last magazine. We're working on the new one right now, as a matter of fact. And I've got a story in here about hyperbaric oxygen therapy, and it's actually doing well for patients with lesions. All right. Hello, Trine. I don't know how to pronounce your name. I don't know if it's Trine or Trine, but hello, Denmark. Nice to meet you. Hi, Rhonda. Carmen is asking, what's a virus that you said why people with lesions don't respond, and what antibiotics kill it? So the viral infections that have been implicated with Hunner's lesions are the polyoma BK. P is in Paul, O-L-Y-O-M-A, polyoma BK, or Epstein-Barr. And there's also kind of secondary studies with HPV and herpes. And because it's a virus, antibiotics do not kill viruses. Just like if you have a viral cold, you don't take an antibiotic for it. It won't kill it. An antiviral would kill it. And that research it's just slim to none right now. In fact, I emailed the International Painful Bladder Foundation a year ago, and I said, what are they doing in Europe to treat viral bladder infections? And even though the European guidelines for IC say you should exclude viral infections, they actually don't have suggestions on how to treat viral infections. And guys, again, if the lighting is weird, it's just because we've got a bad storm and it's crazy here. Absolutely crazy here. Carmen, you're taking DMSO would not be helpful for lesions that I'm aware of. I don't see any reason to be doing DMSO at this point in time. I really don't. I mean, you need to tell your doctor the DMSO is hurting you. If the DMSO is hurting you, then don't do it. I mean, DMSO as a bladder therapy has fallen out of favor rapidly because of the side effects. You don't feel good. Most patients don't feel good when you walk out after having a DMSO therapy. I remember the worst thing. I mean, I've had 8 DMSO treatments. I had them early in 1993. Worst mistake ever made was trying to drive home with DMSO in my bladder. Oh my God. I was dying 20 minutes, 30 minutes later, however long it took me to get home. Barely made it into the bathroom to pee. Rescue installations are far more popular than DMSO because you feel better when you leave normally because it has numbed your bladder. So therapeutically, yes, DMSO is approved by the FDA. I actually interviewed the guy who did the original research with what was his name? Stanley. He was up in Oregon. Stanley something. And he's one of the people who was able to get, that did the formative research that led to the FDA approval. And he actually wrote the FDA guidelines and the spec sheet for DMSO. But he was kind of a fanatic. I got to tell you, they thought that DMSO was going to be the wonder drug that was going to cure a lot of infections. And it turned out that DMSO failed everything but IC. So they were looking in the 1950s, for those of you who don't know this, they were looking for a way to transport kidneys for kidney transplant. Because if you transport an organ in ice, the shards of ice destroy the tissue. So they were trying to find a way to move kidneys from one hospital to another safely, especially if it was at a distance. And somebody happed upon DMSO, and DMSO is a byproduct of the paper industry, the wood industry. So it is a solvent that is derived from some sort of byproduct with the paper industry. And they thought back in the late 1950s it was going to be a wonder drug. They thought it would cure all sorts of diseases. And Stanley, whatever, I think his last name was Jacob, really believed that it was the secret to life. And so they studied DMSO as a bladder installation. They helped create MSM. They were even giving DMSO by IV. And ultimately, in the end, it failed everything, but this little tiny group of IC patients showed a little bit of success. And that's really what led to DMSO being approved by the FDA early on, 40 years ago, as a possible therapy for IC. But it has fallen out of favor dramatically. I love you guys. Seriously, you know what? I love you. I love the way you support each other. So inspiring what you're saying to each other here in chat during these meetings. I want to do this every day. I really do. I swear, I really, really want to do streams every day. I mean, every weekday. I think that's going to happen over on Twitch TV. I got part of it set up already for Twitch TV, by the way. Can IC make your IBS worse because the bathroom is my best friend right now? Yeah, I mean, that's absolutely, because the nerves are shared. So we had research years ago that showed, it was called the pepperoni pizza something. And what they found is when the bowel gets irritated, the bladder also gets irritated. And when the bladder gets irritated, the bowel gets irritated. And that ultimately, in the end, is because the nerves are shared. So what they did is they put radioactive, I don't know if they were radioactive. They put tracers in urine, in the nerves in the bladder, and tracers in the nerves of the bowel. And they followed them back up. And they met at the spinal cord where they merged, where nerves contained both tracers. So that's something that we call neurocrosstalk, where we believe the nerves get stimulated for both organs. And we can throw the vulva in there too. With my yeast infection, I have days where my vulva is screaming, my bladder is screaming, and my bowel is screaming, all because of that neurocrosstalk. Not too often, but it's annoying. Tamara says she's having a terrible IBS flare, which set off your IC. I believe that both IC and IBS play. They do. Yeah, they do, hon. There's no doubt about that. They do. And you have to throw in too, whenever you're having an IBS flare, if you're having diarrhea and you're having spasms, and your pelvic floor is tweaking out. So there are moments when your pelvic floor is so tight you cannot pee. And that only happens to me if I've had an IBS flare. If I've eaten something that has really triggered really bad bowel spasms, that when that's over and you try to empty your bladder, you just literally can't. And you have to wait 15 minutes, 30 minutes for those muscles to relax, throw some heat in there to try to relax that pelvic floor a bit. It's freaky. Robin says she grew up with a basement that flooded when it rained, and where you played with toys, you watched TV, that mold destroyed your health. Yeah. I was saying, I can remember I had my pool act. So for those of you who don't know, I'm IC subtype 5 central sensitization. So I had symptoms when I was in 7th grade, frequency urgency, and then the vulvodynia and the irritable bowel, all that sort of stuff, all the way up through my 20s, right? I didn't have bladder pain until I was 32. And it was only after a pool accident where the pool that I was training in made a massive mistake with chemicals. My diagnosis was actually chemical burn, chemical cystitis. And whoops, sorry about that. My urologist, thankfully, was this really, really great guy. And he listened to me. And in the end, he's who inspired me to start a support group and eventually start the IC network. I kept saying to him, I said, okay, there's a very specific series of events that happens to me. I will have vaginal pain first. So I'll have a day of vaginal pain, then I'll have a day of vulvar pain, and then the third day it hits my urethra and my bladder. And it was a really clear sequence of events that first year or two. I don't detect that sequence of events anymore because normally I'm really good. But you're right, there's just a lot of influence there. Robin says taking B12 by mouth causes your bladder to flare. That's really rare. You can do the shot, but you can't take the mouth. B12 has been okay for decades. You're just, one of those people where you're really uniquely sensitive to it. Aaron says, no geeks here. Hey man, I embrace my geekness. Catherine says, if you're several subtypes, what do you focus on? Well, as you can see, me getting comfortable sitting is challenging right now. I call it the chicken versus the egg dilemma, which comes first, the chicken or the egg? And for us, it's which comes first, the bladder or the pelvic floor? The reality is that they're both involved. The challenge is trying to figure out which is triggering what. One tends to be primary and one tends to be secondary. So, and the exception to that rule is Hunner's lesions. If you got Hunner's lesions are primary because those are open wounds in the bladder that need to be addressed. But if you don't have Hunner's lesions and you're dealing instead with just frequency urgency, what we have to do is try to understand what kind of flare you're having. Guys, is this screen going dark and then light? Okay, so like it just went light. Are you guys noticing that the feed is going dark and then light? That is so weird. So weird. I just think it's just the lighting, the storm is really, really bad. So I'm sorry about that. If it looks like I'm in a dark room, I can't control that. I got lights on. I got a light right here shining on my freaking face. It should not be going dark. Okay, so how do you know what to do? Two ways. You have to think first about if we're dealing with a flare, what triggered the flare? If you're flaring after going out to dinner and eating something, then we pretty much know it's a bladder wall flare. But there's a critical question here, and that is, when is your pain the worst? Before you pee or after you're done peeing? If your pain is worse as your bladder fills with urine and you feel better once you pee, then that's your bladder wall. So we know you're having a bladder wall flare. So you got to focus on things that will calm and soothe your bladder. If your pain is worse, not before you pee, but after you're done peeing, that's your pelvic floor. And so we have to focus on things that will calm and soothe your pelvic floor. They both cause frequency, urgency, pressure, pain, but there are some subtle differences. For pelvic floor dysfunction, you often feel a pulling sensation, a pushing sensation, or it's movement driven. Let's see, how would I say it? Because I was just working with a patient. How did she say it? God, she described it in a really weird way. It's a good way. It's a weird way. What did she say? I always say when I'm having a levator spasm, which which is a spasm of my levator muscle, it's like there's a fist up my vagina that's pulling downward. It's like grabbing my viscera and just yanking it downwards. It's pulling sensation. She had a pushing sensation, like something was being pushed up her urethra or up her vagina. That pushing sensation is definitely muscular. But you know it's muscle really, really clearly if you can't pee. I mean, if you go to the toilet and you sit 5, 10, 15, 20 seconds before you can relax enough to empty your bladder, that ultimately is the hallmark of pelvic floor dysfunction, is your muscles are so tight, it won't let you release your urine. You've got to sit there and relax a bit before the urine will come out. Elaine says, how do you know if you have Hunner's lesions? They have to look in your bladder to see. They can find Hunner's lesions in an office cysto if they use a special equipment called narrowband imaging. If you're lucky enough to have a doctor with narrowband imaging, they can identify a Hunner's lesion through a simple office appointment. Most doctors in the United States do not have narrowband imaging available. They've got to look in your bladder using a hydrodistension with cystoscopy. So that's an outpatient procedure in the hospital. It's now done low pressure, short duration for a very brief period of time. We don't want to traumatize the bladder. We don't want to blow it up. We don't want to put too much fluid in it. We don't want to stress the bladder to any great degree. So hydrodistensions are recommended to be low pressure, short duration, and that's how they would see them. And I've got some pictures. Let's see. So this is a picture of 16 patients with Hunner's lesions. And this is a really good one to look at. They're known for what we call a stellate appearance. So there tends to be a center inflammation, or a center lesion isn't the right word. Anyway, there's a very strong area of inflammation right in the center. And then you tend to see kind of arms of inflammation going out from the center. So you can kind of see that with this one. You can kind of see, although this one's not completely symmetrical, you can definitely see that with this one. Hunner's lesions are known for bleeding massively. When you stretch it, that little center ruptures, and it's called a waterfall effect. And we have a video on our website of what a lesion looks like. And I wish I could screen share. You know what? For those of you that, let me see if I can post links to that. Hold on a sec. If I could screen share and talk at the same time, I could show you the video, but I can't do that right now. But I will be able to do that soon. Hold on a sec. Okay. So I'm going to cut and paste this link into, will it let me do it? All right. So there's the link in Facebook, and here is the link in YouTube. So Maria on YouTube says, how soon can Hunner's lesions come back after surgery? Well, in some cases they don't come back. In others, they might come back in, 3, 6, 9 months, a year. But generally what happens is the more you treat them, you might have to treat them a couple of times before they disappear. Okay. But they can disappear, and they do all the time. And if we could freaking get Lyris back from Allergan, we would have a treatment that would potentially heal them in 2 weeks. Hello, big pharma's priorities, right? Getting back to viruses. For anybody who ever has struggled with canker sores, and I'm one of them, that's the common herpes that 80 to 85% of adults have. I got it as a kid. You usually get it from being kissed by somebody when you're a baby. So I've always had canker sores my whole life. One of the things that I do with canker sores is I use lysine. I have lysine chapstick, and I get lysine pills. And if I have an outbreak of canker sores, which I do like once a year, um, I will chew it up and kind of suck on it. And what lysine does is it shortens the life cycle of the virus. And so that's something that I've actually been suggesting to patients. There's absolutely no research behind it at all, but it's pretty benign. I would be interesting to try, I think, lysine, a little bit of lysine, and see if you feel a little bit better. All right, Lee asked the question, how do I feel about the new supplement that has come out? Let's talk about it. Bladder Builder. Bladder Builder. Bladder Builder is the first of 2 supplements that we will have from this company called Natural Approach Nutrition. The second supplement is Peora, and I'll have Peora in 2 weeks. This is really exciting. It's really exciting. You know, you have to understand that supplements are often the only option for patients, right? I mean, if you don't have insurance, what do you do? What do you do? If you can't afford a bladder installation, what do you do? If you can't, whoops, right, I'm not answering the phone. Hold on, let me look at it real quick. It's my sister. No, Janice, I'm not going to answer. Okay. All right. So the reality of supplements is that they are often the only option for patients. Number one, because when it comes to FDA approved therapies for IC, there are 2, Elmeron, DMSO. That's it. Elmeron has now been linked to eye disease, pretty significant eye disease. So a lot of patients are uncomfortable with that. But we have known for 20 years that Elmeron is rough on people. We know that Elmeron can cause easy bruising, stomach upset, explosive diarrhea, changes in liver enzyme levels, and all that sort of stuff. And so it was really 30 years ago that doctors got involved with developing and formulating supplements, usually at the bequest of patients. So one of the first supplements was Desert Harvest Aloe, because one of the founders of Desert Harvest Aloe had IC. And she was the one who tried aloe 30 years ago and found that aloe helped her. And that led to more research with aloe, which led to today's, common use of aloe as a supplement for IC. That company did a double-blind placebo-controlled study eventually. And they're doing another study right now, I think with Robert Evans. Desert Harvest Aloe has been out for 30 plus years. Cystitis was the brainchild of the CEO of a company who had prostate issues. He created Prostacue and Cystitis. And Cystitis is a supplement that is now considered a therapy up in Canada. It's not a popular supplement anymore, but it is an example of a supplement early on that was remarkably helpful. And then we had Dr. Theoharides, a federally funded IC researcher. And Dr. Theoharides was as part of his work at Tufts University, was asked to investigate the safety of supplements by the state of Massachusetts. And as he was doing that work, he thought the data was so compelling that he wondered, would a supplement help the bladder? And he created Cystoprotect 20 plus years ago. And Cystoprotect has been the top selling supplement really ever since. Cystoprotect does 2 things. It has a bladder coating effect from chondroitin and hyaluronate. She says, where are you? I don't see the support group meeting going. That is so weird. Where is hold on a second. Hello, iPad. Hold on. She's panicking. She's thinking that this is not working. Hold on. I'm doing it right now. Okay. So Cysto Protect does two things: the bladder coating effect from hyaluronate and chondroitin combined with quercetin for an antihistaminic effect. So when this came out, this very, very quickly became a top supplement. Because he's a big IC researcher, he didn't just create it and throw it out there. He actually did a pretty big research study that was published in the Canadian Journal of Urology of over 250 patients who took it about 6 months. And I think it showed that, it was like 15 years ago. What was the data? Like 253 patients took it on average of 6 months, 57% rate of improvement, something like that. Which is, again, now that we know their subtypes, now we understand that it would just be 57. But this was really, really powerful. So we had been waiting for Dr. Theoharides to create the next generation supplement, but he's moved on. He's doing autism now. So a new doctor, Dr. Gio Espinosa, created 5 years ago Cysto Renew. And with Cysto Renew, he took the best of all the other supplements to create a new supplement. So he took the chondroitin and the quercetin out of this, and then he took the aloe out of Desert Harvest aloe, where he used aloe, but then he put in a nerve calming ingredient called lemon balm. Lemon balm is known for its ability to be soothing, and that was really kind of the brilliant change of this formula. This also has L-arginine and L-citrulline in it, but I think the ingredient that makes this particularly compelling at the time is the lemon balm. So bladder builder. So bladder builder represents a new approach to IC and specific, we can't use diseases with conditions. A new approach to bladder health, and it has the chondroitin, it has the quercetin, it has collagen in it. It has a very specific combination of vitamins: vitamin D3, vitamin E, vitamin K2. It's got calcium and magnesium in it, a couple of minerals in it. But what makes it very cutting edge is the fact that it includes probiotics, some important probiotics, some important bifidobacterium, and lactobacillus. But the genius of this supplement is, in fact, the addition of something called palmitoethanolamide, also known as PEA. PEA has been used in Europe and Canada now for chronic pain for years, successfully, very, very successfully, without too many side effects. In fact, I don't think we've even found a side effect for PEA in any PEA studies. And given the opiate crisis, given so many patients being thrown off their medication, having a supplement that might help with PEA is really, really exciting. I mean, with pain is really, really exciting. So bladder builder is a very robust, big formula. There's a lot of stuff in it. And as I told the CEO of the company, I said, listen, I prefer a less is more approach. Because some of us are very, very sensitive. And so I don't necessarily like supplements that have a whole lot of stuff in it. I like to really slim things down so that we can make good, educated decisions. And that's why they're going to have two supplements. So bladder builder is the big supplement with lots of stuff in it. Peora is the slim supplement. That is the PEA and resveratrol. And that is mimicking, although it is different, it's slightly different, the study that was done with IC and PEA that was released 3 weeks ago. There was an IC study released at AUA showing that using a combination of PEA and resveratrol reduced patients' pain dramatically. 87 to 88% of patients using that combination had a significant improvement of their pain at 3 months. At 6 months, 75% had a significant improvement. 25% were pain-free using that PEA it's polydatin, and resveratrol is a variant of polydatin. Anyway, we've been working on this. I mean, they were consulting with me, and they were also consulting with Dr. Ken Peters at Beaumont Hospital. Many variations of this formula before they decided on this specific formula. Patients have been using it now for about 2 months in a couple of different areas. And early data and reports from those patients are really positive. We have nothing concerning to any great degree. So far, this was launched last Thursday on our website. We're going to be the exclusive providers for this for a while. I've only had 2 side effects reported. Side effect number 1 was a patient who got diarrhea from it. And you guys, you just kind of have to know. I mean, we've done the product launch for Cysto Renew, Cysto Protect. We've done all those product launches. So we already know that not everybody can tolerate a formula. And the first month or 2 after releasing a supplement is always like, oh God, we really hope it helps. The early data shows it will. The early patients who tried it showed it will. But now that it's out in a larger population, we're getting more feedback on this. So I had one patient call who said she took it and it gave her diarrhea 30 minutes later. And in talking with her, I think she made a really fundamental mistake because she was on a full dose of Desert Harvest Aloe and a full dose of Cysto Protect, and she added this into it. And I think she hit a threshold where she just did too much. So, and that's what she thinks it was going on too. So I've had one patient with diarrhea. Then I had one patient who reported that she thought it was making her frequency a little bit more. That's out of 200 patients who have it so far. So far, it's looking really good. And again, we now have doctors who are ordering it for their patients. I just had to create a doctor kit last week with information for another doctor in another state. The urologists who are working with it are sharing it with all their other urologists. We really think this is game changing because of its ability to help reduce pain. The question is will you be sensitive to any of the ingredients? And I know somebody contacted me because they're allergic to rice, and this has rice flour in it, so they can't do it. And then somebody else was having an issue with magnesium, and they were worried that the magnesium in this would do it and what would irritate them. And all I would tell you is that magnesium comes in different forms, and this is magnesium glycinate. And so you have to look at what you've reacted to before and see if it was magnesium glycinate. What's exciting about this is it is made in the United States with no cheap ingredients from China. That is something that I insisted on as we were working with them. And because we have grave doubts about the quality of drugs and pharmaceuticals and medications and issues and raw ingredients coming from China. So nothing in this formula is sourced from China in this one and in Peora. Number 2, it is non-GMO. So there's no genetically modified ingredients in it. It is yeast-free. It is gluten-free. You can see the labels on our website. Because it has probiotics in it, we want you to keep it in a cool place or a refrigerator. We are going in the summer, we are going to be shipping this with ice packs, but it is not like Cysto Protect where the gel capsule is going to melt. This is not the same. It doesn't have the same melting effect. So if you want to see what it looks like, it is a yellow capsule. Has no scent to it at all. If anybody else in here has already tried it, I would love to hear your what you think of it. I would love to hear if you have any concerns, because we're passing that along. If you tend to be somebody who is sensitive and you're scared about doing stuff like this, and I will admit, it took me a year before I tried Sister Protect because I'm so freakily sensitive to stuff. It took me 6 months before I tried the low acid multivitamin because, again, I am IC subtype 5 central sensitization. If you're worried about taking something that has a lot of ingredients in it, then wait for Peora, because Peora is really slimmed down with 2 ingredients. And that would be a really, really good place to start. All righty. I will tell you that this is only available on the IC Network website right now for $44.99 for another 3 weeks. We're going to wait a month or two before it goes on Amazon. When it goes on Amazon, it's going to sell for $20 more, $65. And the price is probably going to go up on our website to $48.99, something like that. Peora, on the other hand, the slim down one is going to be under $30. So if money is an issue, then you're going to want the Peora anyway. I think that one's going to be $27.50. So, and again, that's what I keep saying to all these companies. We need things that are cheap. The reason this is more expensive is because of the PEA. The PEA adds $10 to the bottle wholesale. That's why this is definitely more expensive. But the PEA by itself, $26, $27.50. Hopefully that will meet the needs for people who are financially struggling, like most of us are. Cheryl says, do you know if this electrical pain that shoots from my vagina is caused from? Yeah, hon, anytime it's electrical pain, it's a nerve. It's a nerve. So you have a nerve that's being compressed. Tiffany, how do we learn what subtype we have? Go to our website, the IC Network, and watch the video, the 5 subtypes of I, and you should be able to subtype yourself. I can go through the subtypes if you want me to go through the subtypes. I can do that easily right now. But let's go through a couple more questions and then we can come back to that, okay? Yeah, anytime you have an electrical sensation, a burning sensation, a zinging, a shocking sensation, you're talking nerve. And that's IC subtype 4 pudendal neuralgia. And usually that's because you have muscles so tight, they're tweaking the nerves. If you've got sciatica-like pain where it's shooting down your leg, that's a tight piriformis muscle hitting that nerve. So that if anytime you've got shocking, electrical, a vibration, a fluttering, we're looking at nerves being compressed. Marie says, is there any evidence that a gluten-free diet will help with Lehender's lesions? Marie, I don't think anybody's ever studied that. That would be a really good study. You know, you have to have patients who will agree to have hydrodistensions to identify the lesions twice, before the study begins, after the study ends. And then you have to make sure they're going to be absolutely compliant to the diet for a period of 3 months. And that would be the way to do that study. There's no company that would pay for that right now, because ultimately in the end, research studies are usually funded by companies trying to make a buck with a product. So it would be a good study for the National Institutes of Health, the MAP Research Network. Tamara said she had Chinese food and had an IBS flare all night, most of today, which gave you a tight pelvic floor. Yeah. Oh man, I cannot begin to tell you the number of times. Hey, the single worst IBS attack I had was in San Francisco when I was working down there. So I would get up at 5, I'd catch the 6:15 bus, drive an hour, hit San Francisco at 7:45 or 8, whenever I got there, go to work for the feds. That was when I worked for Social Security. It was my first job after college, after I gave up pharmacology because I didn't like the animal work. And so one day we the entire staff went out to eat at a Chinese restaurant. And I'm like looking at this food going, oh my God, what do I do? What do I do? And so I picked what I thought was the most benign food, which was wonton soup. Think Epsom salts. It was so full of salt and so full of MSG. I barely made it back to the office. And we were in the middle of a training. So here I'm in a room with like 15 people getting up every 10 minutes. Explosive diarrhea. And 5 hours later, it was still going on. And I had a 2-hour bus ride home with no bathroom. I was 23. Oh my God. Finally, I wrote it out as long as I could. I think I was pretty cleaned out. Put on like 3 menstrual pads on my underwear. Got on the bus and prayed. Please, God, let me get home. And I did get home. But, welcome to life in the big leagues, right? Yeah. See, again, I have no shame. I'll talk about anything. All I can say is thank you, God, for not letting me have an accident on the bus. Oh, my God. I think after that, I drove to work after that, even though it was harder. Tamara, you and I are twins, girl. We are twins. Tiffany, a pulsing sensation. The pulsing sensation, could be really tremendous inflammation, irritation. But if it's electrical, if it's sharp, if it's zapping you, then it's a nerve. Uh-oh, Sherry is in the middle of severe storms and you've got a red cell over you. Girl, get into the basement. As soon as you hear those things, get in the basement. Kathy says she just ordered Bladder Builder. You're currently taking D-Manos and Allura. You stopped the Elmeron after having eye issues. Can I stop any of these meds since I'm getting Bladder Builder? Won't know until you try, hun. Please just take 1 capsule, see how your body tolerates it, okay? Eat it with a little bit of food. I mean, we've already had patients say they've taken their first pill and they've had no problems with it. But go slow. Thank you, Cheryl. JJ says she doesn't have any idea what a subtype is. Angelique says, I bleed randomly. I've had a hysterectomy. It's crazy when it happens. Please repeat the name of the neuroimaging. I don't think I caught it. Angelique, where are you bleeding? Are you bleeding from your bladder or are you bleeding from your vagina? That's concerning to me. And when did you have your hysterectomy? I have my 2-year anniversary in a week from my hysterectomy. I'm going to do a new video on that. Miranda says, what do I do to get my doctor to agree to get my bladder taken out? I've tried everything and I'm always in pain. I have no idea why it's... Well, Miranda, if you look at the AUA treatment guidelines, bladder removal is step 6. So you got to do everything in step 1 to step 5 before you qualify for step 6, hon. And that would really begin with a good subtyping. You know what? Let's just do that. Let me go over the subtypes, and then I'm going to go over the 6 steps of treatment. And let's make sure we're all on the same page here, okay? Okay. So, and this is the way, if you've been here from the beginning, you know that I had a rocky start to the support group meeting, getting Facebook working, so I was a little scattered. I kind of talked about subtyping a little bit. So this is one thing we know. There is tremendous diversity in the IC patient population. When you go into a support group online on Facebook, you got to understand that you're probably very different from other patients there. And I'm going to explain to you why. Here's the diversity. Some patients have bloody bladder walls that look like hamburger. Hello. Others have bladder walls that have red spots on them, which we call petechial hemorrhaging. All right, where'd that go? I just had that picture. Where did it go? Here it is. Okay. I want you to look at these objectively. Are they the same? Do these represent the same disease? They don't. These are extremely different on biopsy. When you biopsy a lesion, it is massive inflammation. When you biopsy this, not as much, there's hardly any inflammation going on here. Massive inflammation going on here. So we've got some patients whose bladders look like bloody hamburger, others with entirely normal bladders like mine. Both diagnosed with IC. Are we the same? Absolutely not. We've got some patients with terrible agonizing pain, others with absolutely no pain, just frequency urgency, both diagnosed with IC. Are they the same? No, they're not the same. And when you meet other patients and you start talking with other patients, that's where you really see the diversity. You see it in how their symptoms began. Because for some people, IC begins in childhood, while for others, IC begins in old age after menopause. For some people, IC begins after having a baby, while for others, IC begins after chemotherapy. For some, IC is related to a terrible diet, eating a massive amount of junk food and diet soda. While for others, IC can be inherited. There can be some genetics involved. And so what we have clearly been able to establish is that a one treatment fits all approach does not work. Elmiron does not work for everyone. And now we know why. We know about this diversity. And so for the last 10 or so years, researchers around the world are trying to flesh out and better define these diverse groups. And it was the Europeans who got started, the Essex Society, the European Society for the Study of IC, pelvic painful bladder syndrome. They have now defined 12 variants, 12, quote, subtypes of IC, or just, they would call them a variant. They wouldn't even use the word subtype. In Canada, they use 6. In the United States, we do not have a national consensus yet on which subtyping system to use. And so I use a subtyping system that was developed by the IC researcher from Stanford University, Dr. Christopher Payne. Okay. And when he introduced his subtypes, he did it in a very provocative way. Really caught my attention. First, in a negative way, because he argued we should treat IC patients like cancer patients. In my brain, I'm going, oh my God, why would you say cancer? Let's not scare patients. There's no relationship between IC and cancer. And he's like, no, Jill, you're misunderstanding me at all. I mean, completely. When someone is diagnosed with cancer, they are given a very specific diagnosis. A doctor doesn't go in and say, you have cancer, and then not tell you where it is and not tell you what type it is. If you're diagnosed with cancer, you're told that you've got type, breast cancer, type A, variant 1, 2, 3, 4, or for me, my uterine cancer diagnosis was complex endometrial hyperplasia with atypia and a vague architectural complex. A diagnosis of cancer is so specific. It is so specific that both you and your doctor know exactly what to do next. There's a very clear intuitive pathway. And he argues successfully that a diagnosis of IC does not give you any intuitive pathway, that both you and your doctor really don't know what to do next. I mean, they're going to throw out the diet, they're going to throw out Elmiron, but is there a really good, clear plan on how to treat you? The answer is no. No. So how do we get an intuitive pathway? We get it with specificity. We have to get, and that's what I say to patients, is you are an anatomical mystery to be solved. Before we can talk about treatments, we have to understand what your anatomy is. We've got to understand what in your body can be triggering these specific set of symptoms. Because guess what? It's not always the bladder. It's not always the bladder. And for many of you, it's not the bladder at all. So let's look at Dr. Payne's subtyping system and see what we can make of that. So if there's one subtype that everybody in the world, every researcher in the world agrees on, it is subtype 1 Hunner's lesions. This is a very distinct patient group. It's distinct not only by how your bladder looks, but again, biopsy results. When we look at those biopsy results, they're different from everyone else. People now believe that Hunner's lesions, Hunner's ulcers, represent an individualized, well, that's not right. That's not the right word. Its own unique disease. And there has been a lot of discussion about splitting lesions off of IC or out of this patient community completely and giving you your own disease name and your own research. But at this point in time, that has not happened. And in fact, they had a meeting last year where they decided not to do that because they feared there would not be enough funding for that. So if you have Hunner's lesions, then you have got to do lesion-specific therapy. And I posted a link earlier on our website. You can go to that link. You're going to be doing fulguration or laser therapy to basically destroy or kill the center of that lesion. So again, remember the stellate appearance, right? There's a center. So what they try to do is they try to cauterize this to seal it. Or what they'll do is inject a steroid into the middle of it. Remember, inflammation, if the inflammatory process usually means that your body is fighting something. When you get a splinter, it turns bright red until you get that splinter out. If you've got an infection on your hand, it's going to be bright red until that infection is cleared. That's the inflammatory process happening, the mobilization of white blood cells into the area to fight the battle of whatever the heck is happening there. So there's a big fight happening in your skin, in your tissues, when you've got Hunner's lesions. And again, now we know what we think is happening there. We think it's a viral infection, with 2 research studies finding 2 distinct viruses in the urine of patients with Hunner's lesions, but no virus in these patients. So we see virus in this group, but we don't see viruses in this group. Okay, so that's IC subtype 1. And if you're going to have a hydrodistension, it is very, very important that you have a discussion with your doctor about what he or she plans to do if they find Hunner's lesions. Because the last thing you want is for them to do nothing. And that's the really sad thing here, is that we've got patients who have been told they have lesions, and yet they've never been treated. They've never been treated. Or if they're treated, they get treated months later, where you have to have a second hydrodistension, which interestingly makes the doctor more money and the hospital more money. Ideally, if they do a hydrodistension and they find a lesion, they treat it at that time. So you need to make sure you have a discussion with your doctor. If you find lesions, what are you going to do about it? The doctor says nothing. You're going to say, why? Let's treat it. And the doctor might say, well, I have a wait and see attitude. And your answer is going to be the AUA guidelines and say, I would prefer not to waste time. If we can treat it, let's treat it. Or the doctor might say, I don't know how to treat it, or I don't have the equipment to treat it. And if the doctor doesn't have the equipment to treat it, then you move on to another doctor who would know how to treat it. Okay. But there's nothing worse than working with a patient, crying their eyes out. They've got lesions. They've had lesions for a couple of years. They've never been treated. And the thing is when you treat a lesion, the pain usually goes away. 85% of patients who have their lesions treated, the pain improves dramatically. And so we want to make sure lesions get treated correctly. Okay. And let me just say too, listen, if you're one of those patients where you've got pain as your bladder fills with urine and your bladder's screaming all the time and you're not getting better, what the AUA says is, hey, let's revisit the diagnosis. Let's make sure we haven't missed something. And the odds are for some of you, this is what they've missed, Hunner's lesions. And we want to get those treated. All right. The second variant of okay. Oh, and actually one more thing, just so you know, in Europe, only patients with Hunner's lesions are diagnosed with interstitial cystitis. Everybody else is diagnosed with bladder pain syndrome. And that is correct. That is actually based upon our knowledge and the biopsy results, that makes sense. In Asia, it's called hypersensitive bladder syndrome. In the United States, we call it ICBPS. But you should be fair warned that there's probably going to come a time when we're going to be saying patients have bladder pain syndrome and leave the interstitial cystitis diagnosis to Hunner's lesion patients only. They're resisting it now because of Social Security and the ruling there, and patients don't want that to happen. And we're worried that patients who have gotten Social Security disability on a diagnosis of IC, that might be reviewed and yada, yada, yada. So in the United States, we call it ICBPS. All right. I see Marisa asks, will any of the supplements help with Hunner's lesions? Nobody's tested them with Hunner's lesions, Marisa, so I have no feedback for you on that. I just don't. I wish I did, but I don't. All right. I see subtype 2, bladder wall driven. These are the patients whose symptoms are being triggered by the bladder wall, and this is what their bladders look like. Because, hello, the bladder, like any other part of the body, can be injured. You have to remember, the bladder only knows one language: frequency, urgency, pressure, pain. The only way that the bladder can tell you there's a problem is by giving you those symptoms. Unfortunately, you associate those symptoms with infection. All of us did. Hey, doc, man, I was up all night peeing. I've got burning. I really think I've got an infection. The doctor would throw an antibiotic at you, right? Okay. But what if I told you that a bullet wound to your bladder would give you the exact same symptom? Or a stab wound? Or a chemical injury? Chemotherapy. If you've gone through chemo is well known to do this to the bladder. The irritants in chemotherapy are profoundly damaging to the bladder wall. Or if you, unfortunately, played with ketamine at some parties, ketamine can do this to the bladder wall. Or if you are a massive junk food junkie, diet soda drinker, that can do this to the bladder wall. Strong acids can irritate the bladder wall. Eileen says, what does a normal bladder look like? A normal bladder looks like this part. It's just white with vague blood vessels in it. You know, I think I have, hold on. I was going to say, I'm looking for my pictures. You know, I've got to find my pictures. I've got my pictures from mine 2 years ago. And they just don't have red spots on it. It's just normal, healthy tissue. I mean, it looks like the palm of your hand. A normal healthy bladder would look like the palm of your hand, although you would see blood vessels because the skin isn't quite as thick and it's all lit up with light. So that's what a normal one would. All right. So how do you know? Okay, Kay asked a good question. Is the bladder wall the same as the bladder lining? No. Here's a three-dimensional picture of the bladder wall. And it makes sense. I mean, think about it. Your bladder is designed to hold toxic waste because urine is body waste. Urine contains ammonia and urea and byproducts of any and every chemical that you've been exposed to, including cigarette smoke. If you're a smoker, man, you got 20,000 carcinogens floating around in your urine. So how can a bladder hold irritants for hours at a time and not get damaged from the time we're babies? Well, this is why. Your bladder has basically, kind of 3 to 4 layers. You've got a mucosal barrier because your bladder's like your mouth, right? It's a hollow organ covered with mucus. So you've got a mucosal layer. Then you've got the urothelium, which is a layer of cells. And these are the largest cells in the single body. And then underneath that, we've got blood vessels and we've got nerves, and then we've got the smooth muscle of the bladder. So it's ultimately this nice thick coating that protects your bladder from irritants in urine. But you have to remember that this coating was designed for life thousands of years ago. Thousands of years ago. Not today's modern day life. I come from Norway and Sweden, North Norway. What were my ancestors eating? World's blandest diet. They were eating fish. They were eating deer. They were eating berries. They were eating lingonberries only when they were ripe. Only when they were ripe once a year. They had salt, right? We didn't have acid to any great degree other than if we ate unripe fruit, as compared to somebody who grew up and their ancestors are derived from the equator, where you were eating mangoes and papayas and citrus and oranges and stuff like that. From an evolutionary standpoint, your body has more defenses for that than I do, because my ancestors have only been exposed to this stuff in the last 800 or 900 years. In the end, you have to understand that today's high acid diet often exceeds the threshold of your bladder's ability to defend itself. It becomes the equivalent of a chemical injury. So if you're drinking green tea every day, green tea is very high in acid. If you're only drinking coffee all day or soda every day or lemonade all day or orange, your body is not designed for that. And eventually, that daily acid load is going to start impacting the health of the mucosal barrier. Now, what else affects this is estrogen. For women in the trigone area of the bladder, it is extremely estrogen dependent. So when you're young and you have lots of estrogen, you have lots of mucus. When you're older and you have less estrogen, you have less mucus. Thus, the ability of your bladder to defend itself is compromised. That's not a disease. That is getting older. So with less mucus, you're not going to be able to tolerate the acids that you grew up on. You are exceeding the threshold of your body's ability to adapt to that over time, especially for women who are perimenopausal and beyond. So if you lived on soda and tea in your 20s and 30s, by the time you're in your 40s and you start losing this area, you're getting acid right down here on fragile cells and nerves, and it's going to hurt a lot more. Injury, superficial injury, I think an injury, trauma to the bladder wall. Now, another group in this group is chronic infection. And we talked about that when I started this. In this subtyping system, Dr. Payne says there are subtypes. So we know in IC subtype 2, bladder wall driven, We know that there can be chemical injury. That's one variant. We know that there can be estrogen atrophy. That is another variant. We know that there can be fungal infection, viral infection, and perhaps chronic bladder infection in some, but not all patients. And that is why having next generation urine testing is meaningful. If you believe that you have an infectious process going on, you can prove it by having a next generation urine test done. Now, granted, it's going to show all the good bacteria as well as any potential bad bacteria or fungus. But as I was going through the research when we just started, what we're finding is that some patients have candida in their urine. Okay, is there a subtype? Okay, this is a subtype for the bladder lining. She asked, is the bladder wall the same as the bladder lining? Is there a subtype for the bladder lining? This is it. This is that subtype, and you would have a variant in here. So if you have pain as your bladder fills with urine that is relieved by urination, so the fuller you get, the worse you feel, and as soon as you pee, there's a sense of relief. That tells me that your symptoms are coming from your bladder wall. If you are diet sensitive, your symptoms are coming from your bladder wall. So generally, for this workup, there are things we want to do. Normally, they would check your urine for infection, but you might have to up it with a next-gen test. Number two, we want to look at the quality and health of your skin. If you're over the age of 40, we have to consider the role of estrogen atrophy, especially, or if you've had a hysterectomy at a younger age, it's there, it's happening. And for those patients with estrogen atrophy, the treatment is going to be using a little bit of estrogen cream to help your body produce mucus. You know, some people say, well, will a treatment heal the bladder? And the answer is no treatment's going to heal the bladder. The only thing that's going to heal the bladder is the bladder. But healing is happening all the time. What we just want to make sure is we're creating an environment to support healing, and we're at the same time addressing any deficiencies, perhaps like estrogen. For some people, using an estrogen product might be really helpful. All right. IC subtype 3 is the largest subtype. This is pelvic floor dysfunction. So these are the patients whose symptoms begin after a muscle trauma or whose flares begin after a muscle trauma. So if your symptoms began after a car accident, after a fall, after having a baby, after having a rape, if you had been raped or sexually abused, it turns out that injured muscles become weak muscles. And then weak muscles, because your pelvic floor is supposed to hold up your tissues, and if they get weak, what happens is they overcompensate and they start getting tight. And when you have tight muscles, you get restricted blood flow. Kind of like the research study I talked about earlier, where they find low blood flow in the pelvis of some patients. So pelvic floor dysfunction can cause all of the symptoms. Here. Let me get my demo here. You guys, we are going to have a giveaway. Just so you know, we will be giving away a couple of bottles of Bladder Builder towards the end of this meeting. So if you stick around, you might get some Bladder Builder. Okay, here we go. Pelvic floor. When your pelvic floor muscles get weak, they can't do their job, so they overcompensate and get tight. And before you know it, they get tight. And you know that if you squeeze hard on your arm, bam, look at that, all the blood flow disappears. It takes a couple seconds for the blood flow to come back. Well, that's kind of what happens to the organs in your pelvis when you've got tight pelvic floor muscles. So tight pelvic floor muscles have been linked to bladder issues, to urethral issues, to vulvar issues, vulvodynia, constipation, rectal pain. For our purposes, one of the ways that we can distinguish if you've got pelvic floor dysfunction is, again, with that simple question: when is your pain the worst, before you pee or after you're done peeing? If your pain is worse after you're done peeing, that points to your pelvic floor. that points to muscles. Where if your pain is worse before you pee, that helps us point to the bladder wall. Pelvic floor patients tend to have more movement-driven symptoms, or you feel a sensations when you moved, pushing up, a pulling down, heaviness, feeling like you're carrying a bowling ball around in your pelvis, feeling like something's falling out of you. And of course, the number one symptom is that you can't pee right away, that you go to the toilet and you sit there or stand there for 5, 10, 15, 20, 30 seconds before you can relax enough to empty your bladder. So what is the treatment for pelvic floor work? It's not Elmeron. It's not diet. It is muscle therapy, pelvic floor muscle therapy. If you've got a tight muscle, no pill is going to fix this tight muscle. What's going to fix this tight muscle is a finger working the muscle out, right? It's gonna be you doing stretching, the right exercises, but ultimately in the end, you have to work with a physical therapist first to find the name of the muscle. Some of you have pain on your left side. Some of you have pain on your right side. Some of you have pain on both sides. For me, my pelvic floor pain is dominantly on my left side, and it is dominantly my levator muscle and my piriformis muscle. So some people say, well, can't I just do Kegels? And the answer is hell no. Kegels are designed to tighten muscles. That's the last thing we want to do. You already have muscles really tight. We've got to relax them. And so you can't fake it. You cannot fake it and do this on your own. At least once, try to work with somebody to help you figure out what muscle is the issue. And then you want to get one of the books. You want to get Ending Female Pelvic Pain, Ending Male Pelvic Pain, or Heal Pelvic Pain, or the Interstitial Cystitis Solution, all of which explain what you can do. And when you come back from the pelvic floor assessment and you know your levator muscle is a tight muscle, you can also go onto YouTube. There are a lot of videos from pelvic floor physical therapists now that will give you stretches and other things you can do. But again, you cannot fake it, my friends. So the books are, let's see. Heal Pelvic Pain. Here we go. These, I think, are the best books right now for this. Ending Male Pelvic Pain by Isa Herrera for men. Ending Female Pelvic Pain for women. And I'm telling you, you're going to learn more. You're going to learn more in 5 minutes with this book than you've learned your entire life. Like, one of the things that you can do when you've got tight muscles is this pose. It's called the prayer squat. What that does is that puts your pelvic floor muscles exactly where they need to be. So if you're at the bank, oops, hold on, stay. If you're at the bank and you're having a flare, just come on, just drop down and put your feet, put your butt on your feet, like pretend you've dropped your keys, and sit down here for a couple seconds. And it really puts your pelvic floor exactly where it needs to be. And it's a really great way of kind of nipping a pelvic floor spasm in the butt. Of course, don't stay there for 5 minutes, for God's sake. You're not going to be able to get yourself up if you do that. You got to be moderate with it. A couple seconds, Okay, so that's pelvic floor. IC subtype 4 is pudendal neuralgia. And actually, it's bladder pain subtype 4, pudendal neuralgia. All right, so here we've got bladder wall injury, muscle injury, and now we're talking nerve injury. So these are the patients with the electrical pain. These are the patients with persistent genital arousal disorder. These are the patients who have shooting electrical pain down their legs, or a sense of vibration. When you sit down, something's moving. There's a vibration. There's an uncomfortable sensation. That is usually an irritation of the pudendal nerve. So as an example, I was working with a guy who did a long car ride. No, not a long car ride. He was a Harley rider and belonged to a motorcycle, a recreational motorcycle club here in Northern California. They did an 8-hour drive through the redwoods up the coast up to Eureka. Well, it was a long drive. And when he got off the motorcycle at the other end, he had this terrible pain. And that was because the seat of the bicycle was pushing directly up into his prostate, directly onto a nerve, and it injured that nerve. So these are the people who sometimes they have a traumatic accident. They fall on their tailbone. And that's a very common trigger for a nerve injury. Or bike riding. We see this in a lot of elite athletes, triathletes. I was working with an Ironman athlete who, Hawaii Ironman athlete, as a matter of fact, really at the pinnacle of his career, when one day suddenly he had frequency urgency pain. And, we're talking, and he's very upset. And we go over his symptoms, and his symptoms, not diet sensitive at all. His symptoms were really muscular to me with a nerve component to it. And I was like, dude, seriously, you have been sitting on a hard bicycle seat for 2 decades. It's going to take a toll on the pelvic floor. And he didn't believe me. And he called me like once a month, and got to the point where he was just in agony. And his mother was worried about him. He was worried about it. And I kept saying, have you had your pelvic floor assessed? He goes, no. It's like, I don't believe you. And it's like, just do it. For God's sake, you got nothing to lose. Just do it. And he finally went and had it tested. And he had a very severe pelvic floor injury that was impacting a nerve. Okay. So it happens, guys. It happens. So generally, the nerve is injured because of tight muscles. And so the treatment is really going to be about releasing those muscles and maybe calming those nerves down, maybe with some nerve appropriate therapies like amitriptyline, gabapentin, something like that. Okay. And then our last subtype is my subtype. It's the most interesting subtype to me. It is bladder pain syndrome central sensitization. So this is, in many cases, the inherited subtype. My mother, my sister, my aunt, my cousin, my grandmother, generations of women have a sensitive bladder. But not only do we have a sensitive bladder, we have wicked sensitive skin. We are drug sensitive, which is why I'm very careful about taking new things, because I hate taking new stuff. I hate it because I never know how I'm going to react to it, because super sensitive. I'm sensitive to foods. Central sensitization patients, they find that there are some foods that don't work in their body in general, not just their bladder. For me, it's chocolate. It destroys me. You want to talk bawling my eyes out, cramping for days? Give me chocolate. Wherever that is in my body, it's like poison until I poop it out. When it's out, it's over. But I can feel it everywhere. I can feel the spasms moving down my lower intestine. Oh, it's terrible. We have a wicked sense of smell. I have found now 3 gas leaks. I just found another one in my neighborhood a month ago. I have found 3 gas leaks that no one else could smell until they came out and tested it. We had a gas leak in our street from a crack in the street. And then chemical sensitivity. We don't do well with a lot of chemicals. So the odds are, for those of you who have central sensitization, even though you don't know it, you've already changed your environment. You've gotten rid of the strong smells in your home. You're not using scented candles. You're not using Glade plugins. You're not using Febreze because they bother you. So what does central sensitization means? It means that we have a centralized nervous system that is easier to turn on. And it may be an evolutionary adaptation, because what's the purpose of having good sense of smell? Well, go back 1,000 years. It was how we found food. It's how we found food. And so I don't look at central sensitization as a disease. It is the reality of my genetics. But for some people, it can happen after injury, after trauma. And they're also looking at a childhood trauma. which I think is really interesting. Because we've all had our moments. I've shared some of my moments in my last meeting, as a matter of fact. We're trying to understand the impact of trauma on the nervous system. We know, for example, that if you badly break your knee and it heals, the odds are when it's cold, it's going to hurt. Why? Well, the bone heals and the muscles heal. But what happens to a nerve when a nerve is injured? And what happens with a nerve is it gets a little bit easier to turn on. It's called the action potential. The action potential threshold is reduced. Thus, it is easier to trigger that nerve. So, you know, I didn't understand any of that as a kid. All I remember is people saying, oh, you're so sensitive, get over it. Well, you can't get over how you're hardwired. This is how I'm wired. This is how my sister is wired. This is how my mother is wired. We were never allowed to use bubble bath as children. Very, very rarely. Because what did it do? It triggered skin irritation for us. We were that sensitive. We knew that. My mother knew that. So for this subtype, hopefully, by me saying this to you, and there's some of you out there going, oh my God, how did she know I have this wicked sense of smell? Well, because you're not alone. Okay, I have it too. We have to accept and embrace the fact that on a daily basis, this modern life in 2019 really can overstress our nervous system in many, many different ways, not the least of which is just through all the chemical crap that we're exposed to. So we have to accept the responsibility on every given day that it is our job to create an environment that will keep our nerves fairly calm. And that can be challenging if you've got family members who don't respect you and don't believe you, family members who, smoke, and if you've got central sensitization and you're around smoke, it hurts. Smells hurt. That's the really weird thing, is that smells hurt. They provoke pain and discomfort. And it's odd. It's really odd unless you're living in this life, in this body. Other people just don't get it. They don't get that you're that sensitive, but we are. And so for this group of patients, the odds are, in fact, I asked Dr. Ken Peters, one of the top IC doctors, I said, what do you do when you have a patient with central sensitization walk into your office? And he was really funny. He goes, I back away slowly. And symbolically, that's absolutely the right thing to do. He says, I'm not going to do anything to irritate their nerves. The last thing I want to do is provoke their nerves and give them more pain. So the theory with central sensitization is that we're not really probably going to do a lot of aggressive testing. We don't want to provoke those nerves. So the testing, unless it's absolutely necessary. Instead, what we're going to do is focus on calming and soothing anything that's hurting. So if you've got central sensitization, you've got a sensitive stomach, you've got sensitive skin, you've got a sensitive vulva, you've got, in my case, a sensitive rectum. And if you treat all of them but one and you leave one screaming at you, your entire nervous system is still going to be pretty irritated. It's important to try to address all of them. So with my vulva issue, whenever I feel it, man, I hit it. I run to the bathroom, I get my coconut oil, and I hit it big time, or my nystatin. I nip pain in the bud as quickly as I can. I try not to let it get entrenched and involved. And it's tricky. It's hard to do. It's tricky to do. So anyway, those are the subtypes, my friend. Now, the question is can I have more than one? Yeah, you're going to have more than one. Listen, if you got Hunter's lesions because your bladder's screaming, your muscles are going to get tight. So, and over time, they're just going to get tighter and tighter and tighter. So if you treat your lesions, that's awesome. But if you don't get your muscles to relax, you're still going to have a discomfort. So you got to get those muscles to relax. And that same thing is true with a bladder wall injury. If you're a chemo patient and your bladder's screaming, your muscles are going to get tight to protect you. But so you got to pay attention to both of them. But if you're pelvic floor primary, you know, and again, I call that the chicken versus the egg dilemma. That's where it gets a little bit tricky because you have no idea you have a muscle injury. Your first symptoms, frequency, urgency. So you call the doctor, hey, I got an infection. They give you antibiotics. They don't work. You go back to the doctor. Eventually, the doctor goes, maybe you got overactive bladder. They throw overactive bladder meds at you like diturban. They don't work. You go back to the doctor months later, and the doctor goes, maybe you got interstitial cystitis, and they give you a bladder installation. They give you Elmeron. Before you know it, you've been on Elmeron for years, and you're not better. Okay, why aren't you better? Well, you're not better because you, underneath it all, might actually have very, very tight muscles restricting blood flow to the bladder. And it's really hard for the bladder to be healthy if it's not getting good nutrition. So again, chicken and the egg. For some, starts with a bladder injury, and then, starts with a bladder injury, and then bam, the muscles lock down. For others, you got a perfectly healthy bladder, but you get hurt and your muscles lock down and they're squeezing your bladder. They're squeezing your vulva and they're squeezing things down there. And we could throw every bladder treatment in the book at these patients and they will never get better because it's not addressing the fundamental problem, which is tight muscles. And some of you, your muscles may be so tight that you've got trigger points. And a trigger point, muscles are really interesting because, I would try to dim it, but I have no muscles right now. Okay. I don't have a bicep anymore, but when you pop a bicep, it pops up, right? When your arm is long and lean, your muscles are long and lean. When your muscle is tight, it bulks up. And the way that happens is when your muscles are long and lean, the fibers are just kind of touching, right? You've got horizontal fibers. When you contract the muscle, the fibers slide. And you can see now that it's making that muscle thicker. Instead of it being 4 fingers tall, it's now 8 fingers tall. That's a perfect example of what happens when you tighten a muscle, right? And then they stay there because there are little tiny pili that attach. So they kind of get locked down. And then normally the pili release and you stretch it out. But sometimes you get locked. There's a little area, a muscle knot that gets locked in that position. So if you have a muscle knot on your back, what do? You have somebody push on it because when you push on it and rub it, it will release. Well, some of you have muscle knots down below. You imagine having a muscle knot by your urethra, by your rectum, by your bladder? How the hell do you get rid of those? I mean, muscle knots hurt. And so what they will do, what the physical therapist will do is so if this is a muscle knot, they will use their finger and they will very gently try to get it to open. And it's going to hurt. If there are some times when they have to numb it, they will do a trigger point injection or they will do dry needling to get into that spot and try to get it to release. And I want to say to you, now listen, some of you walk away from physical therapy after the first appointment. Why? Because it hurts. That, my friends, is the best sign I want to hear. Because if you go have a pelvic floor assessment, and as they do that exam, they're going to touch different muscle groups. And they're going to go low to high. They're going to touch low muscle groups, medium muscle groups, and higher muscle groups. If they can insert their finger and trigger your pain, that is the best news ever. Because they found it. They found it. They found your pain. Holy hell, they found it. This is great news. When you go back the next time, because they're not doing their evaluation anymore. Now they know what they're working with. Now they know they're working with your levator or your piriformis, or actually in my case, my physical therapist has been working on my psoas. My psoas muscles on both sides have gotten very tight. And we've been doing a lot of psoas work. It's been very, very interesting. So at your second appointment, they're going to be much more gentle. And if it hurts, tell them it hurts and they will back off. But the last thing you do, now seriously, people, if they touch a muscle and it hurts and you don't go back, and if you think Elmeron's going to fix that, I would like to sell you a bridge, because it just won't. Muscle pain requires muscle work. And we've proven it in research studies. In 2008, the very first pelvic floor physical therapy study came out. It was a multi-center study funded by the National Institutes of Health. And that is what sparked all of this, because that study showed that pelvic floor physical therapy was basically more effective or twice effective than almost every other therapy out there. And when that study came out in 2008, that's when everybody had to go, oh, holy hell, wait a second. Maybe this isn't a bladder disease for some patients. If pelvic floor physical therapy makes patients pain go away, then maybe it's a muscle problem for some patients. And that was the genesis of the subtyping. In 2008, when that study came out, we all had to go, uh-oh, maybe this isn't a bladder disease in some patients. And now we believe that actually pelvic floor injury is the biggest subtype in men and women. Let me give you an example. A early 20-something young man who has struggled with frequency urgency pain for 4 years, since high school. Really disabled, not leaving his house. Life is a mess. Despondent. He was a football player. So question number one is, well, did you sustain any pelvic injuries playing football? And he's like, oh man, yeah, a ton. I was hitting the pelvis all the time. Like, okay. So and we know that a history of athletics is a common foundation for pelvic floor injury. Whether you're a paratrooper and you fall on jumping out of airplanes where you hit the ground hard. I was working with a Denver Bronco football player a couple months ago. Same thing for him. Okay, but let's get back to this kid. So with this kid, great guy. So, we're talking on the phone. It's like getting a history, like he's a football player. Okay, so we already know a lot of history of trauma. And then I asked him a question that nobody really else had asked him. And he said, can you tell me exactly what you were doing when it started? And he said, yes. I fell off the ski lift. My football team went skiing and I fell off the ski lift really hard. And within the next day, he had all the symptoms we associate with IC. And what he had was a massive pelvic floor muscle injury that had been exacerbated also by a lot of other injuries on the field. So in his case, they threw him on the prostate med, all that other stuff. None of the medications are going to work for him other than maybe a muscle relaxant. What he needed was a proper pelvic floor workup. And that's where we got him. I actually haven't talked to him since then. I hope he's doing okay. If you're watching, call me. I want to hear from you. But, that's the type of story over and over and over and over that I get. It's so interesting. And again, the problem with online groups and any support group now is if you go in there and you're newly diagnosed and you read all these horrible stories, you're going to think that's you. And it's not you, because they may have a completely different subtype than you. They may have untreated Hunner's lesions. Alrighty. So now let's go over the 6-step treatment protocol. Now, the 6-step treatment protocol was released in 2011 before the subtyping system. So the 6-step treatment protocol really works for bladder wall injury. Okay, so let's just go over that really quick. This was created by the American Urology Association, created in 2011, revised in 2014. Why? Because back then, doctors around the country were treating patients very, very differently. It was crazy. Some doctors were doing surgery. Other doctors were telling them it was all in their head. Some doctors were doing Elmeron. Other doctors, I mean, there was no consistency at all. So what the American Urology Association did is they convened a committee of 30 IC experts and patient representatives to create a treatment protocol. And they did a damn well good job. Again, now that we have subtyping, we're going to have to adapt. They're going to have to adapt this, in my opinion, but it's a good start. And what I want you to do, I want everybody to go to auanet.org. In the right-hand corner is a link to guidelines. I want you to go to the right-hand corner, click on guidelines, go to that page, search for interstitial cystitis, and I want you to print out 3 copies, one for you to highlight and learn from. Let me tell you, you will have so much ammunition to use with your doctor if you have those guidelines in hand. So that is your homework. Go print it out. It's 60 pages long. It's organized beautifully in little statements. Read it. I want you to print a second copy for your doctor. And I want you to print a third copy to always have in your car. So if you ever have to go to a new doctor or go to the emergency room, you can hand it to them and say, here are the guidelines for this. It's important because these guidelines talk a lot about pain. So nobody can say, hey, you're faking it. You walk into an emergency room with the AUA guidelines in hand and you explain what you've done, instant credibility, instant credibility. All right, so let's go through their guidelines. Their guidelines are arranged with respect to the risk of adverse event. We want you to start at step 1, do everything in step 1 before you go to step 2. Everything in step 2 before you go to step 3, and so forth, okay? So what is in step 1? Step 1 for them is number 1, water intake. Because seriously, I want you to think about this. If you're letting a massive amount of acid sit on your tender mucus in your bladder, there are consequences to that. Water dilutes the irritants in urine. And some of you don't drink water. There are some of you who don't like the taste of water. I don't care if you don't like the taste of water. Your body is composed of water. Water plays an essential role in your health. If you don't drink enough water, your urine gets super concentrated and even more irritating. And the odds are, too, you're going to have hard, dry stools. So the first thing the AUA wants you to do, and that I want you to do, and any reasonable person would want you to do, is get your water intake up. You shouldn't be drinking 1 glass of water a day. Try to drink 6 glasses of water a day, 7 glasses of water a day. All depends upon the color of your urine. If your urine is clear, pale yellow, you're perfect. If your urine is clear with no yellow, you're drinking too much water and you're messing with your electrolytes. If your urine is dark yellow or brown, you're dehydrated. Your urine's more irritating. Okay? The second thing the AUA wants you to do is try to modify your diet. It works. If you're IC subtype 1, subtype 2, you got a bladder injury, you're drinking coffee every day, it's your fault. What does your bladder do? What does your bladder got to do to tell you it's hurt? It gives you frequency, urgency, pressure, pain. So don't keep doing the things that make you hurt. We're trying to create an environment that will support healing. If you pour acid on, if you have a wound on your hand, would you pour coffee on it every day? No, of course not. If you poured acid on a wound every day, what would happen to that wound? It would get bigger and bigger and bigger and bigger. If you're pouring acid on your bladder every day and it's wounded, you're not going to help it heal. You're going to make it worse. Okay? And I don't mean what you can go down to 1 soda a day. You can't. I've had 1 soda in 5 years. It was a small 7-Up because I was nauseous. Okay? You might be able to get away with 1 soda a month, a small root beer, non-caffeinated, low acid. But if you've got Hunter's lesions or bladder wall driven, let's not pour acid on the wound. AUA wants you to try some supplements like Pre-Leaf. Why? Because they contain fewer side effects. And for that matter, we need to thank Pre-Leaf I should have done this at the beginning. Pre-Leaf is a sponsor of this support group meeting. Pre-Leaf can help reduce residual acids in your urine because it's calcium glycerophosphate. So this has been used for 30 years, very, very successfully by most patients. If you're going to go out to dinner, you're going to go eat something you shouldn't eat, you have coffee, whatever, grandma's lasagna, you can take a Pre-Leaf beforehand, and that will reduce some of the residual acids so your urine won't be more irritating. So thank you, Pre-Leaf. They've been a sponsor. They've been incredibly involved with IC for 30 years. I've worked with them for 30 years, or 25 years, and I adore them. But please don't take this like candy. More is not better. Some of you will just, don't do that. It's calcium. If you do too much calcium, you could end up with kidney stones and other issues. So only take it as needed when you're going to eat, okay? AUA wants you to do muscle relaxation, and AUA also says, why not give some acupuncture a try? And there was a new study on acupuncture. I don't remember the details of it. It's just coming out, which is very, very promising. And so, yeah, you know, if you like acupuncture, give it a shot. I tried acupuncture, and it actually was very, I did localized acupuncture, my ankle, and it was fine. But when I tried systemic acupuncture, it was too much, and I didn't like it at all. I felt worse. Okay, but everybody's different. Okay, step 2 is physical therapy for tight muscles, oral medications like Elmeron. Granted, we're not using Elmeron as much because of the eye issue, but this is an example of where Elmeron goes. Amitriptyline, hydroxyzine, muscle relaxants like Flexeril, Baclofen, bladder installations like a rescue installation, and of course, pain care as needed. Step 3, if these don't work after a couple of months and you're not getting better, then bam, let's up it a level and let's see if there's something else we can do. And they put Hunter's lesion treatment in step 3, although I will tell you that when you read the guidelines, what they say is as soon as Hunter's lesions are found, they should be treated. So we have a cystoscopy with hydrodistension, low pressure, short duration, or Hunter's lesion therapy. I disagree with the cystoscopy. It's a whole nother story. If you do have Hunter's lesions, here are treatments, and I have to add hyperbaric oxygen therapy here. Fulguration laser therapy, steroid injection, Lyris, or hyperbaric oxygen therapy. Step 4 is neuromodulation or Botox. So with neuromodulation, the assumption here is that the nerves in your pelvis are not functioning normally. Put a TENS unit to it, try to re-regulate that nerve function. We can do it at the ankle with urgent PC, or at the sacrum, or on the sacral or pudendal nerve with Interstim. Lots of side effects with Interstim. I've talked about this before. We have a database on our website in our support forum of patients sharing their experience with Interstim. Hundreds and hundreds, if not thousands, of severe adverse events with Interstim filed with the FDA. Most patients start with the ankle stim instead because there's no surgery required, and it's much, much less invasive. And of course, Botox. They can also use Botox to turn the nerve off for a period of time. Step 5 is cyclosporin. This is a tremendous anti-inflammatory, works really, really well for patients who have not responded to these others, who have a lot of inflammation going on. Cyclosporin is kind of scary, known for side effects and reducing your immune system and your vulnerability for colds. However, in a lower dose, as it's used in IC in this group of patients, it can be remarkably successful, and we have patients using it. And then last but not least, if all of those fail, then surgery is the option. And that would be potentially an augmentation where they would leave where your ureters attach and your urethra, but they would maybe, especially if your bladder is shrunken and small, they would add a section of intestine to it to increase capacity. Or if your bladder is badly damaged and shrunken for one reason or another, they might remove your bladder and give you an ostomy instead. Very, very, very rare that this is done. I begged my doctor to do this when I was 32 years old because I was in so much pain. I said, I don't care, take it out. I'm done with this bladder. And he very gently said, Jill, I'm not going to take it out because there are lots of treatments you have not done that we're going to do first. And all I can say is thank you, Mark Klein, for saving my bladder, because the treatments work for most of us. It's just the desperation of being in pain drives us to sometimes really radical thoughts like that. The AUA also says that there are some therapies that we no longer do. Long-term antibiotics, BCG, also known as Bacillus calmette-guerin, RTX, racinoferritoxin, silver nitrate, chlorpactin, high-pressure hydrodistensions, and long-term steroids. Alrighty? So there's your 6 steps. Those are perfect for somebody really with IC subtype 2 bladder wall-driven, in my opinion. Okay, let's go back to your questions. Let me get a drink here. Holy hell, can I talk a lot or what? Might have started slow today, but man, I'll work my way up. How do we tell our doctors about this? They told me I have ulcers, but no biopsy done, and I was left with 0 treatment. Courtney, you print out the AUA guidelines, you take it back to your doctor and say you want your lesions treated. And the guidelines say how. And it gives all the research to support it. Allison, here we go. Just had her Hunter's lesions treated last week, and she feels amazing with no pain. She feels normal. Girl, congratulations. Awesome. Now listen, I don't want you to be, if a couple months from now your bladder starts to get sensitive, don't freak out. Don't get upset. You know what to do. And Diana here, she says when she had her Hunter's lesions treated, she felt a world better. Grissette says she's finally found some relief using Elmeron. If you haven't tried it, give it a chance. Grissette, I'm not sure what country you're in, but here, I don't know. I don't know if you're in the US or not, but I will tell you that Elmeron in the last year has now been linked to eye damage, retinal damage. And so we're being very, very careful with Elmeron now. According to those AUA guidelines, what they want you to do is try the supplements first, because they have fewer side effects. And now we know Elmeron has one very, very severe life-changing side effect that could lead to blindness, and that is macular damage. And I've done, you can read about it on our website, the IC Network, right on the front. We have an article on it. Multiple research studies, multiple ophthalmologists are now finding retinal disease. So you got to be careful with the Elmeron. Have an eye exam every year, starting your first year. And if your retina is changing color, you need to stop it immediately. If your retina is not changing color, if you're seeing fine, then you're gold. But if you start having trouble with fuzzy vision, difficulty walking into dark rooms, difficulty walking into a movie theater, and or if the doctor finds that your retinal cells are changing, you need to reconsider the Elmeron. Dale says, considering PTNS for rapidly worsening frequency, is this something urologists do? Yes, urologists do it. He says, I know this is off topic, but you are the only person I've heard who's had it done. Actually, thousands of patients have had it done. It is approved by Medicare and Medicaid and many insurance companies. So lots and lots of patients. I was just in the very, 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 very first group who ever did it. With the doctor who actually invented it. It is considered equal to Interstim, as equally effective as Interstim, which is why they're both Medicare approved. It just doesn't come with the price tag or the side effects. I suspect that there are some doctors who realize, we can't make this statement that this is all doctors, because there are some IC doctors who are absolutely fabulous, who dedicate their lives to helping patients like Robert Evans or Ken Peters or Rob Moldwin. But sometimes there are lesser known urologists who are kind of money factories, and they're in it for the money. And I know this because there was a doctor in Colorado who only did Interstim on patients, and he was making a ton of money. He didn't even tell them about diet. He just said the only treatment for IC is Interstim. And you make a lot of money on Interstim. They, I think 10, 15,000 a pop, Whereas with urgent PC ankle, it might be a couple $100s. So, you kind of have that whole financial, ethical stuff going on. Stephanie, you'd love to have a copy of the Hunter's lesion image. I think I took from a research study. Ravonda's asking the name of the compounding pharmacy that is good for making preservative-free estrogen creams, and that is the Women's International Pharmacy. Women'sinternational.com. They are a mail order pharmacy in Arizona. They do not pay me to say that. I have no relationship with them other than being a client. My doctor is the one who introduced me to them because of my sensitive skin. And I will just say that I have found them incredibly wonderful to work with. Premarin, mass market estrogen cream, well known for causing a lot of extraneous irritation because of all the preservatives in it. Whereas a preservative-free cream is much more gentle on those tissues. Premarin can cost you $200, $250. My preservative-free cream for the same period of time is $40. So for money alone, you get a great deal at the Women's International Pharmacy. And again, I've never talked with the owner or the managers. Nobody's paying me to say that. I'm just telling you that I personally use them and I like them. Ravonda, they have several different bases that they use, including they can go all the way to olive oil and organic olive oil as a base. So if you find that you're one of the really, really, really sensitive patients, you would talk with them on the phone, and your doctor might have suggestions, and they would basically try a couple of different bases to find the one that would work for you. Sasha says, what builds the bladder back up? What builds the bladder wall back up? Estrogen. If you're talking naturally, on the bladder wall, the mucosal barrier is estrogen dependent, so it needs some hormones to get thicker again. Or you can go for the artificial coating, which is the Elmeron or the chondroitin or the hyaluronic in the supplement. Sherry says, 10 years ago, she had Hunter's lesions. 2 months ago, there were no lesions found. Do they come and go? Has my diagnosis changed from IC to BPS? Can I get Hunter's lesions as time goes by? I've had at least 4 hydros that showed the lesions. Well, Sherry, number one, that you are living proof and example that healing is always happening. And I'm so happy for you. That is like happy dance fan. That's so cool. Yeah, baby. I love it. I love hearing these stories. These are real stories. This happens. Healing. I always say to patients, never underestimate your body's ability to heal. Healing is always happening. If you fell and skinned your knee, you'd have a scab on it tomorrow. Your bladder and your body is trying to fix whatever the hell's going on with you. Absolutely. The challenge is, again, we just get in the way. So your question is, can Hunter's lesions come and go? Yes. They have the potential of coming to going. And that kind of makes sense if it's a virus. And I'm not saying yours are viral related. That's just one theory. But I've worked with patients whose lesions have disappeared and have never come back. And I've worked with patients whose lesions have come back. So you just kind of have to take it for what it is. Protect your bladder now. You're in a very, very good place. I'm really, really happy for you. Please do not go back to coffee and soda and stuff like that. Let's protect those tissues. Has your diagnosis changed from IC to BPS? Yes, it would. In Europe, you would now be a BPS patient. Can you get more Hunter's lesion patients as time goes by? Possibly. If it's a viral infection, viruses live on nerves, just like when I get a canker sore, if somebody gets a cold sore, you've got active phases and quiet phases. I don't know if yours is viral or not. I just don't know. But I'm so happy for you. That is absolutely the best of news. I love it. Nicole, great question. If estrogen helps a protective layer, what about when you also have endometriosis? When you have bladder endometriosis, you are told to stay away from estrogen when you have endo. No, you're in a very, very tricky situation when you've got endo, because endometriosis is uterine uterine cells that have migrated up the fallopian tubes into the abdominal cavity, where they can cause all sorts of damage. They get, as you know, they get tight, they can attach to the bladder, they can attach to the rectum, they can even migrate up to your lungs. Endometriosis is brutal. In those cases, you would, what they would probably do is want you to instead do an artificial coating that would protect your bladder. But in the same sense, if you've got bladder endometriosis, we need to know where it is. Has it perforated your bladder wall? Is it on the outside of your bladder? Has it gotten into the meat of your bladder? Has it gotten all the way through your bladder wall and into your bladder? If it is on the surface of your bladder, it would, if they find that when you have a laparotomy, they would normally remove it. If it's perforated into your bladder, they would want to remove that too. I can't imagine that they would keep that there knowing that it would be growing and it would be causing a problem. Crescenda says, does potassium cause flares? Any strong salt will cause a flare. Potassium is potassium chloride. The reason why we had a potassium sensitivity test for a while is when you put salt on a wound, it hurts. If you put salt on a wound in the bladder, it hurts. If you put potassium in the bladder and it triggers pain, that tells us that you have an injured, traumatized bladder wall. So it's diagnostic, not of IC, but of an injured, traumatized bladder wall. So can high salt trigger a flare? Sure. And yet, in contrast, Crescenda, bananas, which are high in potassium, are considered one of the more soothing foods in research studies with IC and diet. So it's a little bit tricky. Taking oral potassium might be irritating. Doing a lot of heavy salts might be irritating. I usually tell patients I don't really want you to eat those really salty pretzels. Unsalted tends to be a little bit better. Carolina, did your hair fall out from Elmeron? I personally have never taken Elmeron. My hair has fallen out. My hair falls out every couple of years. I will tell you, was falling out like mad last year, and falls out after I had surgery. I went through about 9 months. This is one reason why I had to cut it. It's all short now. Gonna cut it again. Gonna be shorter. I love it. Maribel, I bought the bottle. The new product says 5 pills a day, but it has vitamin D, and I can't take more than 2,000 a day. So I'm taking 2 pills a day. Good. I'd love to hear how you're doing with it. Do you feel good with it? Any nausea? Any other symptoms? It's all about what works for you. You never push past your comfort zone. I was working with one patient who was taking she was taking a full dose of Desert Harvest Aloe and was taking a full dose of Sister Protect, but the Sister Protect was definitely hurting her stomach. And I asked her, why do you keep taking it? And she was really desperate and just wanted to take more. And I said, stop it. If it's hurting you, stop it. Back it down less. DB says she has an appointment with Robert Evans in North Carolina in Greensboro next month. Good. DB, you're going to love him. I predict you're going to love him. Most patients do. He's been the doctor of the year the last 5 years in a row. Dale says he has the book Ending Male Pelvic Pain. Love it. Love it. Love it. Again, when we talk about the human body and the fact that it was designed for life thousands of years ago, you think about what the hell we put it through now, sitting for long periods of time, riding bikes, traumas, commuting. Our muscles are challenging. Christine says, thank you for taking the time to do this. I love doing it. I absolutely love doing it. Boy, if I'm feeling depressed and kind of down, best thing I can do is come and talk to other patients, because helping you helps me too. And guys, if you find these meetings helpful, please, you can come to our website and sign up and become a member of the IC Network and get this fabulous magazine, the IC Optimist. It is a patient-driven magazine. My goal with these magazines is within 5 minutes, you can find something that you might be able to try or talk to your doctor with. In our latest issue, which is this issue, we talk about fibroids in the bladder. That's something else that has to be ruled out. If you've got somebody here talked about endometriosis, fibroids are benign tumors that can grow inside the uterus, in the uterine wall, or outside the uterus. They can get so big that they can weigh 100 pounds. Biggest one ever removed, I think, was 160 pounds when I did my research. If that fibroid, heavy fibroid's pushing on your bladder, bam, your bladder is going to hurt. Your bladder is going to hurt. The reason why this became relevant late last year is because we had a research study that found that I'm going to say 85% of fibroid patients had urinary symptoms, I think. And when they removed the fibroids, 65% were cured of their urinary symptoms. So if you've got heavy, awkward, unusual periods, if you have a lot of cramping, a lot of pain, a lot of blood, you want to make sure that you get checked out for endometriosis or fibroids, because those can play a role. Article on hyperbaric oxygen therapy. Very cool. Great patient story with CBD oil from a 68-year-old man who's using CBD oil for the first time, really helping him. Cold and flu strats. Granted, we're hopefully out of cold and flu season now. How to break your loneliness and isolation, which is something that I really struggle with. I think of anything I've had to deal with IC, the loneliness is the hardest. You know, it's just the hardest, because I started having symptoms in my 20s. So for 30 years, I haven't been socializing normally. You know, I mean, I have a small circle of friends. I lost most of my friends. When I stopped playing tennis, and we have to make sure that we break that loneliness. You are not less worthy. I am not less worthy because I have pelvic pain, and neither are you. I think one of the more important articles in here is to how to fit fiber and more into your diet, because fibers feed good bacteria. And I don't know about you, but I went through a period of time, and I still occasionally go through periods of time where I'm dehydrated or haven't eaten enough fiber, and my bowel movements they're like rocks. They're hard and painful. And if you've got hemorrhoids, I've got an internal hemorrhoid that's very, very sensitive, tiny little hemorrhoid that packs a punch. And if I've got anything hard in there, it hurts like hell. And so using fiber to address that is important. Dale here says, smells, loud noises, pressure, and touch trigger your symptoms. I believe that. I think that's classic central sensitization. And the whole noise thing, I think that's really interesting, that some of us are very noise sensitive. I can handle a lot of noises except animals crying. If there's an animal crying, I freak out. I just freak out. We had a deer up in the hills that I think got caught in a fence, and it was up on top of this big hill that I live on. And it was screaming for hours, screaming, before it finally died, or somebody got it or something. And, or if there's rescuing a cat that's in the house for the first time that's crying, I go insane. I go insane. I just can't, I'm an empath. If an animal's hurting, I'm hurting. I cannot sleep. I have to do something about it. So I totally get that. And you want to torture me? You want to know what my deepest fear is? Being put in a convalescent hospital underneath a freeway in the middle of a city. Just kill me now. Oh my God, just kill me now. I couldn't do that. Like the biggest fear about getting older, right? Serena says, my urologist said there's nothing else they can do for me, so they're sending you to pain management. You're suffering so bad. You've been miserable since getting pregnant and having your son 3 months ago. You're mentally done. Serena, girl, you got to call me. We got to talk this week. We're going to walk through this. If this started, did this start before your pregnancy or after your delivery? We got to talk, girl. We got to talk. I want you to call me. you guys know that I answer the phone of the IC network. If you want to talk and you want to have a kind of a second opinion of what might be going on, you're always welcome to call the IC network patient support line. It's 1-800-928-7496. 1-800-928-7496. It's what I do all day, is work with patients. Guys, I should say that I'm the National IC Support Group Leader, and I've been doing this for 25 years, sat on the U.S. Army IC Research Panel. I've got degrees in pharmacology, psychology, and I was a presidential fellow. So if you join this early, you know that I'm a geek. I read the research, and I love what I do, and I can give you some really good context. That's my goal, is to give you context and help you understand your unique anatomy. So Serena, please call me, okay? On Monday? Yeah, you could call on Monday afternoon. I should be here Monday afternoon. Hello, Sandra from New Zealand. Robin, anybody have a bad SI joint? Yeah, me. I've had 2 SI joint injections, and yes, they did help. Didn't make it worse at all, help. But ultimately, in the end, it's been the physical therapy. When you've got a bad SI joint, generally what that means is your hips are out of balance, which means you've got muscles that are compensating. They're not functioning equally. They're working against each other. So, Robin, the most important thing that I have done for my left SI joint is going to work with an athletic trainer who is really helping me get balance and activate the nerves. What we found is my left glute muscles were not activating like my right muscles. My right muscles were doing all the work. And now that I've been working with him for 6 months, I can absolutely feel the difference. Absolutely feel the difference. It's helping. Christine says, you wish you could invite all the physicians you've ever saw at help to watch this. Oh, that's very, very sweet. I'm just saying, Chris Payne would be, I think most doctors would agree with 90% of what I'm saying. They might not use the same language. They might not call them subtypes, but I think pretty much everybody agrees with the groups. Kim mentions Lupron for endometriosis and how it stops endo and how that's going to affect your bladder. And that's, yeah. Nicole says, what a pre-leaf, it causes you severe pain to your gallbladder after only 1 dose. Yeah, switch. Can you take Tums? How about Tums? If you can't do Tums, you could do like maybe try a 1/4 teaspoon of baking soda and a big glass of water. We do the same thing. The fact that you're having gallbladder pain, what that kind of suggests to me is you might have some gallstones. And it would be very, very important that you talk to your doctor about that. Jessica mentions that Lyris is abandoned. That is true. Lyris is deprioritized right now by Allergan. It's just sitting on the shelf. It's infuriating. Robin says, anyone have surgery to remove the bladder? Robin, we've got a support forum over on our website in the IC Network support forum, the original social networking for IC with 50,000 plus members. And we have a whole discussion board on bladder removal. I would encourage you to go over there and read that. It's moderated by one of our best volunteers who's had her bladder removed. JJ, I mean, you really would be, I'd be very interesting to see how you did with Bladder Builder because of the pain fighting ingredient in Bladder Builder, the PEA. I wonder if that would help. I mean, you're exactly the type of patient that we think might be helped by somebody like Bladder Builder because of this PEA. If not, if you don't want to do the whole formula, you do the Piora. It would be very interesting to see how you did with that. Listen, if your bladder has bled several times, there has to be a reason why. What was bleeding? Was it a lesion? Were it untreated lesions that were bleeding? If so, have those lesions been treated correctly? That's what I want to know. You're still having spasms like labor pain, which says, do you still have untreated lesions? You, my dear, are the perfect person to go to a national specialist. If there is any way you can get to see Robert Evans at Wake Forest, Robert Moldwin in Long Island, New York, Ken Peters at Beaumont Hospital, Chris Payne in San Jose, California, or Phil Hanno at Stanford. But ultimately, Robert Evans, Robert Moldwin, it is you have suffered for 11 years. It is time for you to go see a national specialist to figure this out because it really sounds like you might have untreated lesions. That's something that is worth exploring. There's got to be a reason why you're having pain. There's got to be a reason why you're bleeding. Amanda's in Facebook and she says that she had her bladder removed in 2015. Amanda, I'd love to hear how you're doing. Emily says she had external pelvic floor therapy. However, your muscles were so tight and continue to get worse. They sent you to an orthopedic doctor for an MRI. They were not conclusive. You would like to try internal pelvic floor therapy. Do you recommend trying internal? I think that having a proper pelvic floor assessment that includes an internal examination is a must for you. Why did you just do external? Why did you not do internal anyway? You guys are awesome. Cher asks, how many walls does a bladder have? One, but it has layers. It has layers. It's got a mucosal layer. It's got a urothelium. Then it's got smooth muscle. And then in and amongst that, you've got blood vessels and nerves. So somebody asked Amanda, who's had her bladder removed, what the recovery was like. And Amanda says the full recovery is quite long, although every person is different. It's about 6 months to a year. It's quite an extensive surgery with a process for healing. For me, the surgery was the best thing I'd ever done. I've had some setbacks, but even with those setbacks, I don't regret my decision. Feel free to message me and we can talk more. Again, every person is different. You want to really research it. Hey, Amanda, so one of the things that of some of the bladder removal patients that I've worked with, some of the things that have surprised them is insurance coverage for their ostomy bags and for their catheters. That I was working with one patient here in my local support group, and they were only giving her like 3 a day, and that wasn't enough. Not even close. And so she was able to store up a little supply for traveling And then a new care worker threw them all away, and she was devastated because the supply that her insurance company would pay for was very, very minimal. So have you noticed that? Shannon says, you saw a urologist who wants to do Botox as your first treatment? That's an absolute no. Botox is a step 4 intervention according to the American Urology Association. The American Urology Association says it should not be done until you've done through steps 1 through 3. And that's not me, that's the American Urology Association. Suzanne says every time she quits Nexium, she thinks she's having a flare. Have I ever heard of that? No, but it's possible. Hold on a sec. Let me look something up. Isn't Nexium an acid reducer? Yeah. So what the Nexium is doing, the Nexium is actually reducing the residual acids in your urine, in addition to helping your stomach. And so the fact that when you stop it, what that tells me is using an acid reducer is particularly helpful for you. So it would be very interesting to try a little bit of Preleve or, something else and see if you get the same beneficial effect. Suzanne, that makes total sense to me. Lisa says, I have a different doctor since I moved, and the doctor here has given me a different bladder installation, DMSO with Elmeron for IC, which is painful. Past doctor has a heparin mix with the Elmeron in the mixture and a few other items. You know what, Lisa, on our website, in our discussion of bladder installations, I have a whole bunch of formulas for different bladder installations that different doctors have published. I think you should go over there and print that out and talk to your doctor about the different formulas. I would be really clear and say that you're feeling much worse with this formula. And the question is why? One of the things that could be happening is that your doctor is using maybe too much DMSO. The FDA approved dose of 50% has actually been linked to bladder spasms, and it can be more. And that was presented at the American Urology Association 2 years in a row in the form of 2 research studies. I have that on our website in our discussion of DMSO. And so I have to wonder if maybe he's not diluting the DMSO as much, because the heparin and the Elmeron wouldn't cause pain. The DMSO would cause pain. And or is there lidocaine in it? Is he using any lidocaine in it? Because lidocaine is a numbing agent. So most rescue installations have lidocaine or marcaine in them. So would I grin and bear it? No, I wouldn't. I would have a discussion with him about what he's doing, and you can print out the other formulas. And I need you to remember that you're the boss. You pay him, he doesn't pay you. And ultimately, in the end, you get to decide what treatments you're doing. And if you're being hurt by a treatment, then why would you keep going? Why would you keep doing it? That's why I stopped DMSO. As like I just kind of came to a realization that every time I did DMSO, I felt much, much worse. And I just kind of went, why am I doing a treatment that's making me worse? I'm going to do a treatment that makes me feel good. DMSO never made me feel good. So that's on our website under treatment step 2. There should be a link to that. If not, you can pop me an email in our contact form and I will find that for you. Regina, when you had your worst day with IC, did you hurt all the time every day? Yes. July 4th, 1993 was my first day with IC. Worst ever day with IC. I couldn't sit, I couldn't stand, I couldn't lay down. All I could do was pace and cry, and I did it all day for out. You never forget that. You never forget falling on the floor and begging God to help you. And for me, it was July 4th, 1993. I wish I could Okay. So to kind of give you context there, my first year with IC started with a pool accident in 1992. I don't even remember the day it happened. I don't remember the time of year it happened. I only know it happened. And the pool admitted they'd made a mistake. That year, I drank a quarter cranberry juice a day. And I'd seen my first appointment at Kaiser like the next day, 2 days after that pool accident. I was diagnosed with chemical cystitis. And somebody said, well, I grew up drinking cranberry juice, right? So I internalized that. I drank a quarter cranberry juice a day for a year, not having a clue I was pouring a massive amount of acid on a chemical burn. And at the end of that year, what started out probably as a mild to moderate burn was an oh my God, I want to die burn because I bathed it in acid every single day. And that was the epitome that happened at the end of that year, that worst day. But I am living proof that healing happens because I don't have that anymore. Once I backed off on the cranberry, did the urgent PC to break the pain cycle, things got better, much, much better. But teaching me about the diet and understanding IC as injury rather than illness was critical to my understanding of this. Critical. And it helped me make better decisions. You know, when you think of it as an illness, you're thinking, I'm not going to let this illness rob me of something I love. I'm going to have the coffee anyway, right? When you think of this as an injury and you go, okay, I've got an injury in my bladder that's healing. Gosh, would I pour coffee on an injury on my bladder? No. No. Rocio is saying, is HPV related to IC? Human papillomavirus is related to all things going bad in the pelvis. We know some strains of it are related to cancer, genital cancers, rectal cancer, urethral cancer. I do believe that I saw one study that suggested that there could be a link with exacerbating IC symptoms maybe a year or two ago, but I don't remember the specifics for it. I can tell you that the HPV vaccine is very, very important to get. My generation, we didn't have HPV to any great degree. Our big concern when I was in my 20s and 30s was AIDS and HIV. You know, my generation was a generation where sex was not fun because we all knew we could die from HIV. So there was no sexual fun for Jill Osborne. No way. No way. For this current generation, HPV is an equal concern because it is the cancer that it can trigger is nothing short of devastating. I was working with a 32-year-old woman, young mother, diagnosed with HPV-driven urethral cancer. They had to remove her urethra, her bladder, her ovaries, her fallopian tubes, her uterus, and her cervix because of the HPV cancer. And then somebody had the audacity to tell her she'd be back at work at 6 weeks. And she called me at like 8 weeks and she was barely able to walk. And it's like, yeah, massive, massive surgery. So, you know, having the HPV vaccine is really, really a personal decision. You have to discuss it with your doctor. Adults are having it, even though it's recommended for people under a certain age, people of an older. I mean, I'm telling you, if I were in a new relationship with somebody, which I could be right now, because there's somebody that you know, is very nice that I've gone out with a couple of times, but moving over into sex, whoo, you know, especially for somebody who's been in a lot of relationships, I would really think about getting that HPV vaccine first. I just, I can't, you know, I can't kind of keep that at a distance because I'm still dealing with hysterectomy complications. When I you want to hear some truth, absolute truth. When, as a single woman, when I go out with somebody, I ask myself, is this guy worth a week of pain? And if he's not, you know, I mean, I don't just think about sex as attraction. I think about sex as, okay, there's a ramification for me, and that could be pain that could last for some time. So I don't play one night stands in any way, shape, or form. Makes for a little bit of an unhappy Jill in some ways, but I'm sorry. But so whether it's HPV or pelvic floor flare, I mean, it takes a lot of thought. When you have pelvic pain, you really think about dating in a very, very different way. We all deserve love and compassion. No doubt about that. Absolutely no doubt about that. But it's not without ramifications, and it takes a lot of careful thought. Oh, Stephanie's teaching me something. Stephanie Hun, I love it when people teach me. So Stephanie is saying, so it is with the utmost love and respect, right back at you, Stephanie, that endometriosis does not come from the uterus. Its DNA is different from normal endometrium. It's similar to the uterine lining, but not the same. There's no evidence to support the theory of retrograde menstruation as a cause of endo. Oh, I agree with that. I never believed that. There are limited doctors that understand and treat endometriosis well. Most gynecologists don't understand, diagnose, or treat endo well. It's important to connect with true endometriosis specialists if possible. Nancy's Nook Facebook group is a good educational resource. It is not a support or discussion group. It is more like a library. I believe all the old endometriosis myths until I had a hysterectomy and my endometriosis continued to get worse. Through my research, I was lucky to find a doctor diagnosed with IC. Stephanie, girl, would you write an article for me for our website on this? For our magazine? I'd love to talk with you. I would love to talk with you, maybe collaborate with you on that article. I love and respect and appreciate that. Hey man, you know what? People I love the most are the people who very kindly and respectfully tell me what I can do better. I love this. That's a gift of, the gift of being older is you realize that it's impossible to know everything. You do your best, you study, I study, but I don't necessarily study deep endo, and I love your info. So I would really love to hear more from you. I'm going to like that right there. I liked it. Christine says she has no symptoms of endo, but has stage 4. Interesting. Maribel saying she's using CBD oil with no THC and it's helping. Hey, I just ordered our first CBD oil from hemp for the IC Network store. It's coming from Douglas Laboratories. Just ordered a case of it. Give it a try. Douglas Laboratories also makes Cysto Renew. Hey, now listen, you guys have been sticking around for over 3 hours. I think it's time for a giveaway. Don't you think it's time for a giveaway? I think it's time for a giveaway. And our giveaway is 2 bottles of Bladder Builder to 2 different people. So if you've already ordered your Bladder Builder, please don't enter. So Kathy Lambert, can I take Bladder Builder if you're allergic to shellfish? There's no shellfish or fish in it. Not sure about the sulfa. The sulfur. I will, you know what? I swear I asked that. Hold on a sec. I swear I asked the manufacturer that question last week. Hold on. Let me see if I have an answer for that one. Hold on, my friends. Hold on. Look at that. Emailed me today with more research. Hold on. I swear. You know what, hon? Let me send him I'm going to send him an email right now. Hold on a sec. Let me do that. doing a live support group meeting. Have a patient who is allergic to shellfish and sulfur. Can she take bladder builder? I know there is no shellfish, but how about the sulfur? All right, we'll see if they, I don't know if they're still at work, but if they are on a Sunday, I'll let you know. Kim's on the bladder builder first week, just on 1 pill a day. Okay, Kim, awesome. Amanda. Robin, the SI joint injection, I was really scared of it. It was so easy. I could not believe how easy it was. First of all, I was in and out of the doctor's appointment in like 5 minutes. It was stunningly how easy it was. The hardest part is them just finding the right spot on your back. You just drop your pants a little bit, expose your hip area. And then I think he used a little portable ultrasound or something to find the joint. They marked it with a little ink on your back, and they knew exactly where to do it. I had no issues with it at all. I was stunned. I realized I had worried needlessly about it. I would do it again today if I could. I mean, I really liked it, but you can only do it once or twice a year. Ravonda says, you had a biopsy done, you have skin cancer, currently having to do vinegar water soak in the area. Could this cause a flare? I doubt it, but the stress of having skin cancer certainly would. I've been there. I think it's probably just taxing to you. Amanda says she's never had problems with your insurance covering your supplies for your ostomy. Good. I'm so glad. 5 to 6 times a day. Oh, you have an internal pouch. Yeah, she had an external pouch. So she was having to reuse the pouches and just getting lots of infections from it. Sahar had been working with me, terrible pain. Went to Dr. Peters. He injected nerve blocks, and you're doing better. Awesome sauce. I love it. Hon, you need to talk to Dr. Peters. You need to talk to Dr. Peters about what your next step is. Is it pelvic floor driven? We need to know that. Regina issues a careful warning. Anyone who's nutrient deficient, be careful taking acid reducers. It's one of the things that cause severe potassium deficiency. I wasn't aware of that at the time. The doctor had me on high dose because of gut issues. Regina, thank you so much for sharing that. Christine says that her husband's having a difficult time or had a difficult time coping with the fact that sex causes you pain because he doesn't want to hurt me more, which is so true. So Christine, we were all sitting around one day around the kitchen table, because we have funny conversations. I love having weird conversations about stuff. So we were just sitting around the table going, gee, what can a couple use if a woman can't have intercourse? If a woman cannot have a penis in her vagina? Surely there's something out there that would be a nice substitute. And who knew? There are sex toys too, and we actually have sold them. The fleshlight, think of a flashlight. The fleshlight looks like a flashlight, except at the bottom, you could have it on your bedside table. Nobody would have a clue. It's not a flashlight. It has an orifice, and you can pick the orifice you want. It can be a mouth, it can be a vagina, it can be a rectum, it can be a little slit, doesn't matter. And you can actually put that between your legs, and your husband can thrust into that. Or you can have a tenga, Tenga. Tenga is a Japanese, it's like the Japanese aerospace industry meets the sex industry. Tenga is a fabulous line of sex toys for men. They have one called the Tenga Flip Hole. It's like um, a cylinder that you can flip open, and on the inside are ridges that mimic a female uterus. And it also has buttons on it in different spots. So you can thrust into that, and then you can push on buttons to kind of make it more pleasurable for him. So the Tenga Flip Hole is actually the all-time favorite for IC couples. So I would look at those. Sometimes creativity matters. The other thing I would really say to you and to say to every woman is, if sex has at one point in time been painful, it's very natural to become afraid of it. And sometimes what happens is we wait until we try to have sex again to figure it out. And that's really unfair to your partner. You've got to understand what works and what doesn't work with your body first before you try to explain it to somebody else. And now, what does that mean? That means masturbating. You've got to regain confidence in your comfort level, whether it is just a simple touch or a stroke or having a clitoral orgasm versus having a vaginal orgasm. Clitoral orgasms are fabulous, and they are not pelvic floor traumatic at all. Vaginal penetration leading to the stimulation that way can be more irritating. So you can go instead for kind of outer course, touching, stroking. Clitoral stimulation can still give you the satisfaction. And then at the same time, having something like a Tenga Flip Hole or a fleshlight would still give him the sensation of thrusting into something, I mean, guys, it happens. It's okay. Becky, if you're interested in Bladder Builder, great. Bladder Builder is currently for sale in our store. I got a response back from the manufacturer. It says PEA might have some sulfur. They're checking on it. Stephanie says she'd love to help write an article, and not doing so well right now. That's okay. Good, hun. Hey, man, let's do it. When you're feeling a little bit better, let's do it, okay? You can reach me through the IC network, guys. Just go to our website and go to the contact us, and you can email me directly right through there, or icnetwork@mac.com. Annie, I've talked about Bladder Builder. So Bladder Builder is different from all the other supplements because it is tackling pain. It has an ingredient in it. So it has similar ingredients to the other supplements. It's got the chondroitin for the bladder coating effect. It's got quercetin for the antihistaminic effect. It's got L-arginine and L-citrulline that we find in other supplements too. But it has a few more vitamins in it, a few more minerals in it. But what makes it different from all the other supplements is it's got some probiotics in it, some bifido, some lactobacillus, and most importantly, it's got PEA in it, palmitoethanolamide, which has been used in Europe and Canada for years as an over-the-counter supplement to help with chronic pain. And so this is the first supplement to have a pain-fighting ingredient in it, and that's why I'm so excited about it, to have something that might reduce pain and discomfort. For those of you who've been thrown off of your opiate medicine, to try to come up with other options for you is such a priority for me and for us. Lucy, can subtype 5 skip generations? No, it just gets passed down. I mean, you just might have a mild form of it. All right, my friends, tell you what, let's not give away 2 bottles. Let's give away 3 bottles of Bladder Builder because I got a case. Last week, 3 bottles. All right. Let me get my Post-its. Okay. So the way we're going to do this, we're going to do it by numbers. Now listen, there's only 20 of you in. Let's see, there's only 40 people watching right now, 50 people watching. So I'm going to write down a number. Hold on. All right. I have written down a number. The first 3 people to come within 2 of the number are going to get it. You can vote multiple times, guess multiple times. So we're going to go, you got to be within 2 of the number to get it. And one of you is already fairly close. Facebook, go ahead. Go ahead. I'm not seeing it on Facebook. All right, Liz C. Liz C gets 1. Liz C, you are the first one on YouTube. Marilyn Rutecki on Facebook, you get it. Marilyn Rutecki is number 2. Becky Gregg. Becky Gregg. Actually, yeah, Becky Gregg. All right. Some of you were after that. So guys, it was all a matter of timing here. So you can stop voting. The number was 15. All right. Liz C on YouTube. Marilyn Rubecki on Facebook. Becky Gregg on Facebook. You are the 3 winners. On Facebook, you need to, I need all 3 of you to email me, icnetwork@mac.com, your snail mail address, and we will do this, okay? So I'm putting your name, and if I don't hear from you in 24 hours, I'm going to give your bottle away. So you need to, I'm going to give it to the next people in line because there were other people actually guessed the number. So I need to hear from you quickly. If I don't hear from you quickly, I'm going to give it to somebody else. I'm sorry, but it just is the way it is. Otherwise, I will have your bottle sitting on my desk with your name for weeks, and I don't want to do that. I want to get these out as quick as I can. Okay? All right, good people. I really, really hope we were able to help today. Last call for questions. Last call for questions. Hey, I'm going to throw something out there for me. Anybody play Fortnite? You want to know how I decompress after working with IC patients and doctors, stuff like that? I play Fortnite. All right, Liz Kuhn. Good job, girl. I got your address. Becky, Marilyn, please email me your address, icnetwork@mac.com. You guys, at our next meeting, we'll be giving, I'll be giving more Bladder Builder away. I'll have a couple more bottles to give away. And I really, really, really want your feedback on it. Please tell me how you do. Please tell me what you think. I'm going to be sending an email out to everybody who's bought it within a month. We really want your feedback. We really want to know how you feel. Do you feel better? Do you feel worse? Again, the formula was vetted by the top IC researcher in the world. We have patients who have used it for a couple of months now. And so far, all the feedback is very, very positive, although we have One patient who reported diarrhea, and one patient who thought her frequency was, she shared that she thought her frequency was worse. So anyway, but that's out of hundreds and hundreds. So icnetwork@mac.com, Marilyn, icnetwork@mac.com. M is in Mary, A is in Apple, C is in Charlie. Kathy, I've got the manufacturer investigating right now. They already emailed me back during the meeting, and they're checking to see if PEA has sulfur in it. So, hon, if you can email me to icnetwork@mac.com and send me an email saying you're the one asking about that, and then I will email you back their response. Okay. Sherry says my grandsons play Fortnite. Hey, you know what? There's a lot of people that play Fortnite. I play with a lot of people who are older. You know, we're just not very good. It's the kids who have really nimble fingers who are really, really good. I just go in and run around and hide. I'm the queen of second place because I'm not good with face-to-face fighting, but you give me a little rifle from a distance and I'm pretty accurate. But anyway, I just like to play. And it's fun. You laugh so much playing Fortnite. It's weird. So if anybody out there plays Fortnite and you want to play, hit me up. Send me an email. I'll friend you on Fortnite. Ravonda, can you use a microgen test after taking an antibiotic? Sure you can, because what it's going to do is it's going to find bacteria that weren't killed by the antibiotic. All right, now listen, my friends, I always end these with an important message. If there's anything that you remember from our conversation today, from this meeting, is that, and I'm looking at you right now. You know who I'm looking at. IC is not your fault. You have done nothing wrong. There is no shame. There is no blame. I don't want you carrying a burden that you're damaged goods. I don't want you thinking that you're unlovable. I don't want you thinking that you're not, oh, here, hold on. I just got distracted here. Karen, if you can send me an email, I will email you that name. Okay. I just don't want to put that publicly because I don't want to be stalked, but I'll tell it to you privately. Okay. icnetwork@mac.com. Go ahead and send me an email. All right. You have done nothing wrong. This is not your fault. You are not damaged goods. You deserve love. You deserve care. You deserve support. What I don't want you to do is hide it. I don't want you to be one of those people where you will care for everybody else in your family. Man, if you got a loved one, a partner who was hit by a car, or if you have a cat who was hit by a car, you will pick them up, you will take them to the doctor, you will sit there, you will bring them home, you will love on them forever, you will worry forever, you will give them all the love and support that they deserve. And yet for some reason you think you don't deserve that same love? Don't hide this. If you need help, ask for it. If you need love, ask for it. If you need a hug, ask for it. Don't expect your partner to read your mind. If you need a hug, walk up and give them a hug and say, I can really use a hug now. Okay. I need you to do 3 things every day. 3 things every day. Number 1, do 15 minutes for your bladder or for your pelvic floor. Don't be passive aggressive and not do your physical therapy as I have done in the past. In fact, I have not done it for 3 days. I need to do it. Whether it's driving by Starbucks, whether it is making an IC friendly meal, whether it is going out and taking a walk, doing your pelvic floor work, do something for your body. I'm not asking you to do big things. We're talking about building a house brick by brick. We're talking about making success brick by brick, small steps every day. It works. The second thing I need you to do is do something for your soul and your spirit, whether it is picking up a phone, calling a friend that you haven't talked to forever, going to church, taking a walk in the redwoods, reading a Bible, listening to John Edward, listening to Joel Osteen, whatever makes your boat float. Do something that will give you peace, spiritual peace. And most of all, you got to work on your knowledge level here. And that's the biggest challenge of all for those of us who are on social networking, is nobody wants to read anything anymore. Doesn't work. You got to do your research. Every day I need you to read one good article about IC or pelvic pain. I don't care what it is. Come on to the IC Network website, go to the ICA website, go to the National Library of Medicine, go to Pelvic Health Rehab. There are a lot of good blogs out there. Please don't read the epitome of the National Enquirer articles like that promise quick cures. Come on now. I need you to learn how your bladder works. I need you to learn how your muscle works. I need you to learn how muscle fibers work. I need you to understand the layers of your bladder if you've got a bladder wall injury. Read it. If you don't, you will not be able to advocate for yourself and for your loved ones. Nobody can ever say to me, IC is in my head. I will slam them down with research. Really. Nobody could ever say that to me, aside from wanting to punch them in the face, which I won't do, but believe me, I'll be doing it in here. I will hit them with research. I want you to be able to do the same thing. All right? Okay, we have a couple more comments. Elaine, thanks for a great meeting. Elaine says, thanks for a great meeting. This was my first one and it was wonderful. Well, aside from my rocky beginning, I think it's been a good meeting. Maybe the first 30 minutes, not so good. Dahlia is saying, your son was diagnosed with IC by a urologist, took Elmeron without any improvement, then was referred to a different urologist in a bigger hospital. They did a lot of tests, said his symptoms didn't make sense and wants him to see a psychiatrist. Well, can I swear? Will you guys hold it against me if I say the F word? F them. F them. How dare they put that burden on your son? How dare they do that to him? I want you to go see a national expert. The odds are, I will tell you, the vast majority of kids that I work with, I'm saying in teenagers, 20s, muscle injury all the way. Muscle injury all the way. And I would love to talk to him. I would love to talk to you. Let's see if I just did this again with another father-son a couple of weeks ago, and we were able to pinpoint it, create a list of symptoms, create a list of questions for the doctor, and then get to the bottom of it, which in his case absolutely was a traumatic muscle injury. And so, Dahlia, if you want to call me this week, if we can get him on the phone, I would be happy to talk with you first and give you some questions to explore. If you want to get him on the phone, if he's over 18, not embarrassed about it. It's one of the things I think I'm pretty good at is talking with younger folks who've got this. And I bet we can create some context to try to solve the mystery of his symptoms. The fact that Elmeron didn't help is not surprising. Elmeron is barely above placebo. Elmeron doesn't help, I'm going to say, the majority of patients out there. What I want to know is, number one, is he diet sensitive? Number two, what was he doing when his symptoms began? Number three, what makes his symptoms worse? What makes his symptoms better? I mean, there are a whole lot of questions that we can ask to try to solve this mystery, Dahlia. And I would love to work with you to see if we can help him, okay? My phone number for the IC network is 800-928-7496. And you know what? It might be Saturday afternoon, but if you want to call me right now, I will answer the phone for you and talk to you now, because this is important. I mean, you're all important, but this is really important. Telling a boy it could be all in her head is almost criminal, in my opinion. So if you want to call me right now, 800-928-7496. Okay? If not, call me next week. Hey, Marilyn, I'm writing down your address, but then I want you to go in and delete it, please, because it's, you know, you've just given it to other people. Slide. 7045. Okay, hold on. I'm gonna delete that now if it'll let me. All right, it's hidden. Okay. Becky, did you, if you emailed me your address? So Kathy, Kathy Lambert, if you're still in here, the manufacturer emailed me back, and what they say is while they cannot see any sulfur in it directly, they want you to show all the ingredients to your doctor if you are susceptible to allergic reactions, because people who are allergic can be allergic to other things as well. Allergic sensitivity is not an exact science. This would be a good case, they said, if we had samples. So anyway, please do that. 3% of the US population is allergic to sulfur, they just said with this research. Okay, Becky, I did not get your address by email. I see. Oh, yes, I did. I got it. I got it. All right. Very, very good. Okay, Marilyn, I did just delete your address out of the log. Dahlia, here's the number. 800-928-7496. You can call me right now. I'd be happy to talk with you. Okay. And Kathy, for the sulfur, they want to know if you've ever taken MSM. You ever had if you've ever taken, I can't imagine you would, but just out of curiosity. All right, folks, it has been a record 3 hours and 51 minutes. I loved every minute of it, and I will be back. I'm going to do maybe a drop in this week. I want to get to the point where we actually have office hours every day or a couple of times a week over on Twitch TV, where we can do this too. It's a lot easier to work on Twitch TV, and you guys will be able to talk to each other more too. Plus, I'll be able to show you stuff, show you a lot more stuff. So, all right, everybody, I'll see you later. Be well. All right, hold on. Where's YouTube? All right, there you are, YouTube. I had you blocked up with email. All right, goodbye, YouTube. I'll see you later.